Done, sir.
Um, Good evening, everyone. Myself, I'm Dr. Prashant Gowda, Secretary NNF Karnataka chapter. So we are continuing the web series of how to build a high quality but cost effective at the same time, trying to look at every aspects of building a good health infrastructure. So we are continuing that series, and today we have wonderful speakers who will be talking on the purchasing techniques, which are the things which are essential, especially for the obstetrics and neonatal and surgical equipments. When you start, that's like must have equipments, and good to have equipments, and very good to have. So must have the basic ones, the next level ones. So we're going to categorize and tell us and give us an idea. Then we have that will be done by Mr. Vinod Nair. Then the second talk will by Mr. Ganesh Prasad. So he will be talking on digital equipment in OBG. Can you mute? Yeah. So he'll be talking on digital equipment in OBG. What are the latest things which are available, like cervical scans and breast screening devices. Then we have Dr. Chinmay Umarji. He'll be talking on digital equipments in OBG, the wireless CTG and NTS. Then we have Mr. Madan Sampath. He'll be speaking on the surgical equipment like laparoscopic equipment, bronchoscopic equipment, cystoscopic equipment, all scopies, which based on the need of the hospital, how to decide and how to consider purchase of the equipments. So it's going to be a real good bargain with our today's session. I'm sure all the audience and participants who are there and will be watching this with our recorded session is going to get benefited with this wonderful bargaining session about from the doctor side how we bargain for certain equipment, and as a owner of the hospital how you bargain back and get the essential ones, and how smartly you utilize your capital investment and funds capex, how you decide. So I request now Mr. Vinod Nair to start the session. And meanwhile, I request my President NNF and Vice President NNF Karnataka State Chapter to speak a few words, and after that, quickly we'll start the session. Over to you, Kotreshi sir. Kotreshi sir. Kotreshi sir.
When we start our hospital, most of the times we depend upon invoice and the whoever comes representative for the selection of things. So we should select the material which is needs to our hospital. The service oriented is very important. Patient comfort also very important. So both the things you have to think, as well as OBJ and as well as neonatal things. Once you select and get the things done at the reasonable cost also you have to thought. When we purchase the bulk, we get the reasonable rate also. Even in an individual purchase also, we can get a lot of concession also. So once you think of thought of how to deal with the things, with very good initiation, I think. And most is eco-friendly and friendly instruments are required. Our instruments, whatever the things are, should be useful and it should be easily operated from us. Then it will be benefited for the both patients and as well as doctors and as well as who are the staff working along with us. That is the most important aspect. And I am proud to say on behalf of NNF Karnataka, our boys are doing a wonderful job, Dr. Prashant and Dilekar. And thank for all the audience and participants and all the delegates and as well as the speakers who are in touch with the things to upgrade our knowledge about the instrumentation regarding medical fertility. Thank you.
Yeah. Thank you, sir. I request Kishore sir, who has been instrumental in this webinar, who has given a lot of inputs. He himself is an excellent entrepreneur and excellent experience in the setting up of hospital, excellent clinician. And we are very proud that he'll be soon representing, and hopefully we pray that he's going to represent Karnataka as an EB member in IAP. And we are very, very proud that sir has provided all the necessary help to construct this particular webinar by providing excellent speaker for us. We are, as a Vice President of NNF Karnataka and as a clinician, sir has done extremely good job. We hope to see you as a Karnataka representation in IAP in the center, sir. I request Kishore sir to
Thank you, Prashant.
speak quickly and then over to you. Yes, sir.
Thank you, Prashant, and thank you for the kind words. And I sincerely thank NNF Karnataka for hosting this and all the members and office bearers of Karnataka. But most importantly, the speakers and Madan especially for having agreed in the last minute when we asked the CEO and he nominated Madan, and Madan agreed readily without any hesitation. All the speakers, Vinod Nair, Ganesh Prasad, and especially Ganesh with the GenWorks, the support given to NNF Karnataka in organizing all this. Otherwise, it would have not been successful. Over to you, Prashant.
Mr. Vinod sir, kindly introduce yourself and then please start the session. Thank you, Kishore sir. Thank you, Kishore sir.
Good evening, everyone. My name is Vinod Nair. I'm the director for a company called THC Private Limited. We're based out of Bangalore. We manufacture high quality surgical instruments in Kerala, and we manufacture all kind of hospital furnitures. So today I am going to take you through two topics. One is the hospital furnitures, and second one is the surgical instruments. When you purchase the hospital furniture and surgical instruments, when you start a new hospital, what all the aspects you have to look at and how you can bargain with the vendors, which all things you need to take care when you buy a new item of hospital furnitures and the surgical instruments when you start a new hospital. So when things to keep it in mind when you purchase a furniture for a new hospital, first you need to think about the durability of that product which you are buying. It can be a ICU code to a normal structure. When you buy, you find out what is the durability of that one. And second is the comfort of that particular product, which can be, ICU code when you buy that it can be the form, it matters, the mattress matters. So what is comfortable when it's moving, how the casters of that particular product which is working. So a lot of comfortable itself is part of that one. Other one is quality. The quality matters, which you are not buying. You are buying this for one time, and when you are long term, you need to use this for 5 to 10 years. In that, my quality is one of the key point which you need to look in when you are buying the hospital furniture. Second one is hygiene. Medical facilities are exposed to people with the harmful germs and infections. So surface, table, chairs, and the material which is using, especially the resin which is using, the leather which may be using, you need to be very careful when you are talking to your vendors what kind of products which they are using for that one. Next one is ethics, which you know that one hospital is it's actually a business as well. It's not only we are taking care of the patients. And when the patient comes, when you're coming into the room, the look, the wall colors, as well as the way which position the codes in the ward as well as special rooms, how they position and what kind of is an ABS-based ICU, whether the bedside locker is positioned over there, whether they have a cupboard over there. That's also matters of that. So when you are selecting one item, think about the colors of your wall as well as what kind of products which we need to buy based on the new hospital, how it's coming up. The other next aspects which you look at the people size. So Indian, not much, but in outside there is different size of people. We can see 6.5 feet to 5 feet, but in Indian culture, which it's all 5.5 to 6.5 kind of normally people. But we need to see that what the size of the people when you are going that one buying some item. Example, in front of ICU, you should see that you can see that one in some hospital attendant come bed, which is actually you can make as a chair in the daytime and the night you can make as a bed. So that all, depending on the height of the people, we can adjust it. Second, the environmental safe products, we need to make it. A lot of anti-bacteria will be there. So when you the same thing which is connected to the hygiene one, which you have to think about that one when you're buying this one. So some of them you need to be very careful that one, the cleaning. Some cleaning is one thing which your housekeeping people can easily clean. When you're that kind of products, you need to look into when you're buying the healthcare. So the last one which I want to say, don't look at for a cheap option, because saving a few rupees is not something to aim for which purchase of furniture for your medical facility. Busy healthcare institutions should focus on quality furnitures that is expected to last for longer. So this is the common things which I want to say when you are the owner of the hospital, you have to check with your vendor or manufacturer the common things we need to keep it in mind. So this is the thing which I want to say, the quality when you are buying a furniture, the normal the powder coated all furnitures will be using something called a CRCA. It's called rolled cloth anneal. It's not an MS product. So you have to take the best quality, that is the best gauged CRCA pipes or sheets or tubes which is using for a ICU coat or a ward coat or for the general wards. The gauge of the sheet and pipe also matters. It starts from 16G to 20 above. So if you bargain with the vendor or if you excuse the vendor, so you may not be able to find out what kind of gauge he's using, but you should ask your vendors what kind of gauge sheets and pipes and tubes which you are using when you are manufacturing a hospital ICU coat or ward coat or special room coat or even the structure. And when you are looking for nowadays, most of the people, if in their ICU or ward, which are going for a ABS based coats, it's a polymer material, which is, you should see that when there are cheaper quality available in the market, there are very good qualities available in the market. So you should ask them what kind of products which are using the head side and the railing side and the foot side, what kind of ABS material which they're using. Is it durable? Sometimes, if you buy a ready-made coat, if somebody catch one side, the ABS will come out. So you should find out that one, what kind of good quality material which they're using. This thing is mainly we want to see the casters quality, what kind of which they're using, because you know that one, the stretcher and the coats, everything you have to move here and there. See, after 2-3 years, this it started creating problem, the structure. So you have to use you have to ask him to use the best quality casters. If in the 5 position or above or 3 position above kind of this one, you have to ask them a center locked or double kind of casters to use that one, otherwise it won't take the weight. Next is the manufacturing process. So is ERCA pipes, when you're using, it's not a painting, it's called a powder coating. The powder coating process, very good powder coating process, it's a 7-layer. So when we are buying from him, you should ask him after you use cutting the sheet metal, how many layer powder coating is using. That's one of the process which is any powder coated material which is long lasting. You can wash it. That can come in a matte finish. It can come in a different finish or different color. It can come. But the best quality is available 7-layer coating. Now, next is coming to as a hospital owner, you have to bargain. You have to excuse the vendor or the manufacturer. Okay, what is the best price you can get it? Then you have to see that one, how the support from the vendor. So a lot of people are there, they sell it and forget after getting the money. So you have to tell them what is the warranty which you are going to give it. And once, if I call you after 6 months, what kind of support you are going to get it, whether that person is available or his representative available in your locality to support you. So these are the key factors you have to see when you are buying a new furniture for your new hospital or existing hospital. So if you are starting a new hospital, so these are the some of the furnitures which standard coming in our operation theater. I will start from operation theater, then I'll come to ICU on this one. So these are the standard. Depending on your budget, depending on your, the space which is available. This furniture's quantity and the different kind of the furniture will be vary. But standard case in OT, there is first an instrument cabinet will be there. In OT, all the equipments which you are buying should be stainless steel, because that is, we are expecting it's a zero bacteria base. So talk to your vendor when you are buying an instrument cabinet, or when you are manufacturing instrument cabinet, it should be stainless steel 304 grade. So next is coming to the emergency trolley to bring the patient inside. It can be, this is emergency trolley. It's a crash cart, which is using for your emergency medicines. It can be an ABS model coming nowadays, or it can be stainless steel. The stainless steel also should be SS304, which is coming into the OT. Then anesthesia trolley is there, which is again ABS, and it can be SS as well. Then the patient structure trolley, this is which I told, why I told the quality as well as the hygiene on that one, because there is a mattress on the patient structure trolley will be there. So this all matters when you bring the patient into the operation theater. So patient structure is another one. Surgical instruments trolley, which all the doctors knows that one, which is using inside the OT. Myo trolley is another one which is coming inside. This also should be 304 grade. And suture trolley, this also should be a 304 grade. Dressing trolley, which is coming in a bucket and basin, should be again SS304. And structure trolley, again, it can be either ABS or it can be structure the SS. So what are keep it in mind one thing, that when you are buying any furniture for your operation theater, should be SS304. Some people use SS202 as well. If any vendor saying that one, I will give you 304, and if they supply 202, you won't be able to make it, to be frank. So you have to insist them to give anything go to OT is 304 grade. When it's come to the ICU, first one is the ICU codes. The ICU codes can start from 3 position or 5 position. Some of the hospital will go for 7 position as well. And the 3 position and 5 position commonly using in all the hospital. This can be fully electrical or this can be fully manual. So it's depending on your budget, depending on the size or of the hospital, you can select that one, which is coming here. The mainly the casters as well as the side railings and all should be perfectly fitted into that one and should be a good quality. And emergency trolley is other one which is coming in ICU. Again, it's a crash cart which you need it in ICU. This third picture is SS based crash cart, and the fourth picture is the ABS based crash cart. Then medicine trolley, the same thing, somewhat look crash cart only, which is ABS and SS model, again coming into this one. And dressing trolley is another one which we require in this one. And patient structure trolley, which you require in ICU. Surgical instrument trolley also, which you require in ICU. What I want to say here is that one is totally depending on your budget. And you need to make a budget for each and every specialty like this ICU or OT or ward or special room. What all you need it. So a lot of vendors will come and just tell you, I have something like this, I have something like that. If you get into everything, you are going to overshoot your budget. So make a list of that, what you need it in your OT, what you need it in your ICU, based on that one. So you can select that one, what you need within your budget. Coming next to that one, it's into the gynec and OBG. In gynec itself, with the delivery room, there are either in the examination side, there you will get a motorized examination table. You get a manual as well. So depending on your budget and depending on what kind of patients which you want to attract to that one, to your hospital, depending on that one, you can select in examination table itself, whether you need a manual or you need a just vanilla SS1 or you need a MS power coded or you need a very good quality of the electric KEL1. And when it comes to the labor room, it's nowadays everybody use that a 5 position the delivery bed. which come with the ABS as well as different color, pink or whatever color which you want, you can take it. That's what which is again there itself. You need to be very careful with the people. It's a foot operated one is there, then it's a hand operated, remote operated one also is available. So here also, these are the common items coming in the gynec room as well. But you have to talk to them and negotiate with them, because these products are available. If I talk about the cost perspective, it's available from 70,000 to 2 lakhs rupees, which is available depending on the brand, depending on the company, depending on the manufacturing sales guy is doing, based on those matters. When it comes to the rooms, again, depending on the special rooms, you need 1 or 2 or 3 or 5 position beds, depending on is a special room or a twin room or single room, or it's a ward sharing rooms. That also you can decide that one, what kind of positions which you require. Okay, some humming sound. Okay, so some of the institutions go for all things in ward bed to everything is SS. Because example in St. John's, if you see that one, they go for everything is SS products, because they as per the NMB norms, which is some places which they say that when we wanted to go for SS. One is for cleaning aspects, one is for the hygiene aspects, which they wanted to go for. So if you see that one in ward to the ICU, all the products are SS in St. John's. So next is bedside locker. Bedside locker, you can customize your own way. You can get a ready-made one. You can get an ABS bedside locker. Depending on, again, the budget and the room, you can change it, which is available. Multiple models are available in the market as well as this one. So next is coming in IV stand. You don't need nowadays an IV stand in the room, because these the beds are coming inbuilt IV stand nowadays when you purchase. And step stool, that's required single or double, which is depending on what kind of patient in that room. Pediatric bed, if you required, if it's in a gynae hospital, of course you need a pediatric bed inside the room. And our bedside table, foot table, which is the second last one, is that nowadays the spring model is coming, gear model is coming. So you need a foot table as well in the second room. These are the standard furniture which you are required in the room. Attendant bed. Nowadays, attendant bed is all coming with a storage facility in Bele. We can have the other than the vanilla normal one. So attendant bed is you need it in the rooms. The wards may not be required. And the other things which is coming when you are talking about new hospitals are the patient structure, which is available, the high-end quality, which is the first feature, to the hydraulic model, which is the second one. There are multiple models are coming that one. Also, there is a manual one is available. Depending on the budget, you can select it again. So next is coming to the examination table. Examination tables are nowadays automatic is available. There is manual is available. It's a pneumatic head movement is available. And there are multiple models available. So that also you record that one. So waiting chairs, which you call it's the airport chairs, that's you required for in a hospital. And the wheelchair, which is the SS wheelchair, is available. And there is a foldable wheelchairs are available. Orthopedic wheelchairs are available. There are multiple varieties available. You have to select and choose depending on what you require, what specialty your hospital. Coming to the price, just for your information, what kind of price criteria which we are talking here. See, ICU code, when you are talking about the best quality, which is available for the three position, which is available from around 35,000 onwards. And if 5 position or 7 position manual, which is, I'm talking about only the manual one, which is starting from around 45,000 to 50,000 onwards. So when you go for a motorized one, see the 3 position is available around 45,000 onwards to 6 lakhs. Even that is depending on the model which you are taking. If an imported one and also coming with a 5 to 6 lakhs rupees cap. In special room, again, you can select that one. You need a 2 position, that is your head as well as the leg position only, that is 2 position, or 3 position, you can do the height adjustment as well. So which one you need it? That is available in a manual one, which is available around the 22 to 23,000 onwards, including mattress. I am talking about this, all those things. And what, depending on that, again, ABS, if you go for, you can get it from 20,000 above. And if you go for without ABS model, which is available around 10 to 11,000 onwards for available. And for OPD room, again, you need an examination table. If it's an electrical one, which is available around 35 to 40,000 onwards, and it's a manual one, which is available around 19 to 20,000 onwards. Emergency, again, which is that the structure which I'm talking, the high-end structures are cost around more than a lakh, and the hydraulic one will be coming around 50,000 above, and the manual one, the cheapest one, is available from a 10,000 onwards. So that is the it's a price range which we are talking. In this varies depending on the model which you are selecting, the quantity you are selecting. You have a higher side to bargain to the vendor and get the best price out of that one. But these are the things which I want to talk to you about, the hospital furniture aspects. And things are that one, the first page you see that one, what are the aspects you need to look at when you are buying a hospital furnitures. Second thing, you see that one, what kind of material which is using. That's get the gauges, how many layer, you can see, they can just using a brush, they can paint it also. So, but it should be a proper processing, manufacturing process, it should go through that one, then it will be long lasting. So this is what I want to talk about, the hospital furnitures. So since we manufacture the surgical instruments, I want to talk about the surgical instruments as well. So surgical instruments, which I want to say that one, when you start a new hospital, so you don't have to buy these surgical instruments in the beginning stage itself. So first if it's an existing hospital, you need to assess your inventory and make a list out of that one, what all set you required. If it's a new hospital, create a budget. Once this may not be most challenging process due to the wide selection of instruments, but depending on the specialities which you are going, you create a budget out of that one and find out who is the best the distributor or manufacturer available in your locality, in your area, and just start talking to them. Build a relationship with this guy. So tomorrow he himself will come and tell you, sir, this is the best one is available, or doctor, this is the best one is available. Now, when you are talking to the manufacturer, when you are talking to a distributor, some of the key facts, even though you don't want to know, but if you are owner of that particular hospital, you have to know this one. You should ask the manufacturer what grade of steel which is using. See, this is actually using in the operation theater most of the instruments. See, whether you should ask him whether he is using for a medical grade steel, which is using for manufacturing this one. Some of the doctors will ask you, or if you are in that specialty, you know that one. Some of the doctors want to use the titanium instruments also because it's lightweight and it's using mainly for cardiac and neuro kind of surgeries. So, but in our case, we need only stainless steel kind of this one. Second one is the quality. The quality is the finishing. There are matte finish and the sunblast finish available and glossy finish available. And depending on the doctor's choice, you can select what kind of instruments which they require. And other thing, when you are talking about the manufacturing process, so you know that when you all experience that one, the rusting of the instruments. Well, if one instrument gets rust, it can spread to other instrument as well in the autoclave time frame. So there is a lot of process is part of that one. So like a tempering of this one, and there is a process in the end of the manufacturing. It because the top layer iron content removing to a chemical. That all professional people or professional manufacturers does. So normal steel which is using for manufacturing these surgical instruments will have more than 13% of chromium into that one. So when it comes to the surface, it will work with the oxygen and they will make a layer out of that one. So when we do the process on this one, when any manufacturer do the process of the chemical process at the last, it will remove the top layer of the iron portion. And if you do a proper service and a proper autoclaving, and it can go up to 8 to 10 years without any problem. Only thing is you have to align and to do sharpness between that. Your supplier can do that one between this one. Next is customization, which you know that one. Some doctors need the length of the instruments is different. Some people need the heaviness. Some people need the line. Some people will be left hand. Some people will be right hand. So you should choose a vendor who can customize the surgical instruments for you or the doctor which is coming to your hospital. Next is the durability, which I told that one. The market, everybody say I will give 1 year warranty, but if somebody manufacture any surgical instruments in a proper way, they follow the manufacturing process, it can go up to 8 to 10 years without any problem. Next is cost effective. There is no MRP for the surgical instruments if you see in the market. So it's all depending on the grade of steel which they're using, the way of manufacturing which these people are doing, and what is the process doing this one. It matters for this one. Example, if I tell you one Indian-made Buchwald retractor, which most of the doctors will be using, Indian-made Buchwald retractor, if you buy in India, it will be maximum 3.5 to 4 lakhs in the top state. If you take the same one from Symmetry, it will be 25 lakhs. So that's the difference on this. So you have to talk to the manufacturer and get best out of that one. That's what I want to say. After that one, after sales support, you can get the instruments in the small shops in the market as well, and you can get from a professional manufacturer as well. So after you are using, after 1 year, the OT head sister is saying, or the head is saying, see, this one, this scissor is no sharpness on that one. So you should have a vendor who can next day we call, give a standby or take this one, take it to his factory and service it and get you back immediately. So that is one thing which you need to look into that one. So again, which I was talking about this one, when you are starting a new hospital, even though starting a new hospital, the doctor will have some equipments available, and talk about that one. Take a budget after that one, and create a set which you want it. Because another thing which I want to say, see in the market on the hospitals, which I want to say. So one doctor is coming to your hospital, he may be used some particular brand or some particular instruments. So when he give the list, he will give it with, I want XYZ company with the XYZ part number. So you may get, that may be a carry X into 3 price, but you can get the same thing from other vendor with better quality and better duration and better item. So one thing which if you are a hospital owner, you should see that one, get the list out of that one. Take out the best out of in the market with a cheaper price and try to get that one. And your purchase guy or you yourself can, if it's a startup hospital, you yourself can do a market research and access the manufacturer and distributor, build a relationship with your purchase guy or OT head can get a very good relation with the supplier. So if we make a call, next moment he will come and just he come in, because you need to do autoclave before your surgery. So you have to get, if a replacement or standby or anything, at least 2 to 3 hours before the surgery. So that's what I want to say about what all the aspects which you wanted to look at when you are buying a hospital furniture and when you are buying a surgical instruments. So with this one, I am closing my 2 topics which I mentioned. So if any question, I will take it. I will be available till the end of this session. Thank you very much.
Yeah, thank you, sir. Thank you for your wonderful lecture. There are a lot of questions about the equipment and the purchase, which I've already got it. At the
Okay.
end of all the talk, we'll take up.
Sure.
Now I request Mr. Ganesh Prasad. Ganesh ji.
Yeah, yes, sir.
Yeah.
Good evening. Good
I
evening to everyone.
request you don't need any introduction because everybody knows you. The amount of academic support, what you have done from your GenWorks is phenomenal, and you have always been a great pillar, great foundation, and great support for the doctors. And your vision, your perspective is already been recognized all over the world. You have featured in Forbes magazine, and you have taken GenWorks to a next level even during the time of COVID situation. We are very, very grateful. On behalf of NNF Karnataka, I give a warm welcome, and I request you to speak a few things about you. I know you don't do that, but our audience should know what you are. I request you to say a few things about yourself and then start the session. Over to you, Ganesh ji.
So, thank you, Dr. Prashant, for the kind introduction. There's nothing much to say about me. I've been in this healthcare for 30 years. Spent a lot of time in GE, about 18 years in GE, and I was given an opportunity by Terry Breshingham, who was the MD CEO, and who had a vision to take healthcare to the last mile. She kind of believed that the vision of GE Healthcare at work for Healthier India, to truly transform to reality, she believed that we have to create an organization of scale that can deliver across the country, because healthcare was heavily concentrated on the metros. So now that was how GenWorks was created, and last 6 years, 6 years back we formed this company, and I'm the managing director and CEO of GenWorks. Been blessed with a lot of goodwill, guidance from many of the doctors, as you and the KOLs and senior doctors. Dr. Kishore Kumar is one, who have always been in the forefront of taking the liberty to guide us and to put us on the right track. Because when you are in commercialization, it's very easy to fall into that transactional thinking. But thankfully, the guidance that I've received from my leaders and mentors in healthcare industry have not really allowed me to go that path and look at solution as the route. Because as an healthcare technology company, we are here to solve for the problems that we can improve clinical outcomes, and that's why our focus has completely been on supporting education, because we have to bring in and we have to create awareness about what is available, and clearly we have to do it with an understanding of what problem we are trying to solve for the customer, and that's how our solutions are built. So that's the little bit of an introduction about me and about GenWorks. So digital connected ecosystem, the topic today, is about how digital in obstetric gyne. A digitally connected ecosystem will bring a huge shift in healthcare, and all of us know this very well. And specifically in obstetric gynec, it will bring in the much needed efficiency. And when I'm saying much needed efficiency, it's basically because it's a very overwhelming practice. We know across the country, obstetricians, gynecologists are overwhelmed with patients, and they are completely busy either in OPD or delivering babies, or managing their maternity homes. And in pandemic as this, there's they don't have a respite, because they continue to provide care, and they need to provide safe care. Safe access is becoming very important. Affordable care is important, and prevention is becoming one of the biggest pillar of the new normal. And I believe moving to the digital ecosystem is just certainly going to help in this as an essential for the new normal. So Anviti, can you move to the next slide? So now, what is this digital connectivity? It's basically a digitally connected ecosystem, and where the devices are connected to specialists and through the cloud, and data is available for access anywhere and at any time. And as I said, connectivity starts from connected devices that can be operated by doctors and nurses that are trained and can connect remotely as the need may be. In many cases, these devices, these intelligent devices of which we're going to speak about, can be used by paramedic staff, can be used by the nurse, and the nurse can, a trained nurse or a trained paramedic can perform that study, and the doctor can remotely view and take informed decisions. And in some cases, they can even ask for expert opinion, because when you're available in a connected ecosystem, I believe, as healthcare technology companies, it's our responsibility to put you into that ecosystem, to put the obstetric gynecologist into that ecosystem, where there's a leverage of a technology, where there is an ability to connect, to AI through machine learning, to give you an idea of what we are looking at, to make decisions, that are much more informed, and if need be, you can connect with an expert and take his opinion as well, so that the decision that we are taking as treatment on the patient, is completely in control and completely informed. So that's the whole purpose of building this. While we can keep talking hours together about digital connectivity, in simple terms, for me, it's an ability to connect to the ecosystem, and with the availability of digital infrastructure today and cloud, it's possible, and it's been proven that in many in many areas, especially in times as this, when remote access is very important, safe access is important, availability of specialists are very important, access to specialists is important. This is really proving to be a big boon. And with the next slide. So now let's first start with devices. So today I've been asked to talk about 2 specific devices, but I've taken the liberty to add a few more which are coming up as emerging technology. So the 2 devices which are very important in obstetric gynec, especially in gynec practice, are breast screening and cervical health monitoring device. So both breast screening and cervical monitoring is not just to treat to look for cancer. It's about looking at women's health, and women's health. When I say women's health, when we look after women's health, it's all about screening. It's not about after they have detected cancer, or after they have confirmed the diagnosis. It's about how frequently a woman has to go, and a gynecologist has to have the responsibility to be able to educate the women to take a little bit more holistic care about their health. And there are mandates that are being recommended by NRHM, World Health Organizations, who say that beyond 30 years, every lady has to perform cervical screening to make sure that the cervical health is perfect, and they have to look at the, after 40. Every lady has to look at the do a breast examination and make sure that they have nothing that they have missed, because both cervical cancer and breast cancer, if detected early, can be cured completely and patient can return to normal life. But if we miss this, obviously it's going to create a lot of it's going to become very expensive, and the mortality rates are very, very high. And we know all this. The statistics of cervical deaths due to cervical cancer or breast cancer is alarming. And specifically when we look at these devices, what's very important, what's very important for everyone to know is all of these are point of care devices. These can be used by gynecologists. This can be used by paramedics or nurses who can be trained. These are all protocol-based devices. Let me take the example of the cervical health device that we are talking about from Mobile ODT, who's our partner from us. It's a very, very intelligent device. It's like your smartphone. Trained personnel, healthcare personnel who can, do this examination, can look at the cervix, take a picture. This picture, either they can interpret from the picture, they can look at the picture and they can make an assessment. Visual assessment can be made, and in case if they find something, they can even do pap smear test based on, and you can look at the place, you can look at the site where you are having a doubt and pick the sample from there, so that we don't miss the sample and wrong diagnosis happens later. Number one, you can have a visual assessment. Number two, when in doubt, you can even do a pap smear. And the device has an ability through machine learning and artificial intelligence to be able to point out where the problem is, what the problem is, and can give you guidance as to how you can sort this out. And as much as I can talk about artificial intelligence or machine learning, it's very important that these are only used as guidance. And the expert, the gynecologist, or the expert who has an expertise in reading this can also be called upon, because these are cloud connected devices. These images can be transferred to anyone remotely, and you can look at a expert opinion. You can decide which expert that you want to share this image. The expert can look at the image. You can share with them what the AI finding is. You can share with them what you think about it, and holistically you can take an informed decision. So that's the advantage of a device like this. These are not very expensive, and these are screening devices. And in my belief, screening devices should not cost a lot, because the cost of exam directly depends on the cost of the device. And if the cost of the device is very high, it becomes prohibitive, and it does not bring in the value of screening that we truly want to bring for every lady above 30. To mandate this, as much as even if Government of India or WHO or NRHM have mandated this as much, the cost plays a significant role. And these are very intelligent devices which are not expensive, and anyone can today afford the cost of this test. And more importantly, before the patient leaves the chamber, the gynecologist will be able to make an informed decision on treatment. Especially in women's health, it's very important that the treatment is provided immediately, because most of the time, we hear from gynecologists, we hear from doctors that women doesn't come back because in fear, or they kind of try to overlook this. And when they overlook this, and what could have been treated if we miss the treatment, we miss the opportunity to treat. Everything that's an infection need not be a cancer, and a cervical cancer. That fear has to be taken into factor. And when you treat immediately, if you treat for a mild infection, because we know HPV infections are the beginning to what can develop as cervical cancer. And when those HPV infections can be treated earlier, we can prevent cervical cancer, and we can save so many deaths or the huge cost of care and the sufferings that women has to go through. Similarly, the other device that we're talking about is a very intelligent device called Braster. We evaluated a lot of machines, being in the technology space, and we have a lot of good ability to look at the various advances that is happening in the in these devices, point of care devices. And while we evaluated many, this is one device which we thought was very intelligent, because we all know that compared to normal cells, cancerous cells have an increased metabolism and have a very dense capillary network. So now, if these two conditions are there, which is increased metabolism and which creates a dense capillary network, it's important that the focal temperature of this area rises above the rest. And through a contact thermography device as this, we will be able to figure this out. And they have a very nice technology, very unique technology. While the many are available, it's not that this is only one system that's available. They're very available, but this is a very intelligent device. It has an AI layer, and it can connect remotely to a physician. For me, this is very important. In anything that we do as screening, if you have to do mass screening, if you have to make sure that every patient, I won't say patient, every lady who walks in for a checkup, or who is recommended to have a checkup at some stage of their life, should be able to, should be able to, without fear, without pain, should be able to undergo this, test, and at an affordable cost. And if we can do this seamlessly, and if we can start the treatment early, we believe that we can save a lot of lives, and certainly prevent cervical cancer, and certainly at least if not prevent, we can diagnose breast cancer early, and probably send them for a breast examination, ultrasound examination, and for a mammography to confirm, and start treatment quickly. And early treatment is as good as half the half the job done, which means that we are in the right track to save this life. And as I said, as much as smart devices are an essential, the ability to collaborate with the experts is very important. Healthcare without experts and without expertise is incomplete. So I will never want to say that, though coming from a technology background, with all that we talk about digital, AI, and so on and so forth, certainly the backbone of healthcare is the expertise, is healthcare experts. We have to build in a collaboration mechanism. We have to make sure that they connect with each other. They know each other. They know whom to connect to for what. But it's all done offline. It's done in WhatsApp. WhatsApp has helped in some form of fashion, but that's not a very professional way of connecting. But that's what is there available time. But now, as technology companies, if we can build that ecosystem for you, and at a very, very affordable cost, if we can create an ecosystem where you will be able to share, transfer images, and be in a position to also tell them, give them a little bit of an AI evidence, which comes from the machine learning, which from the ability of the artificial intelligence capability in the machine, or a network, to be able to give them a pointed guidance. It's going to reduce the time of the specialist, and it's going to clearly make the diagnosis much more conclusive than what is possible, than what is possible in silos. And even if you're not connected, in any form of network, even the very fact that this needs multiple touch points, and a lot of manual records have to be taken, preserved, and followed up. It's very important that as technology companies, we complete this ecosystem by giving you an ability to give portability of reports, to be able to keep and allow reports to be available in the cloud for anyone to access anytime. The system should be able to point out the area of where the problem is, and also we should be in a position to be able to connect to an expert. All of this holistically is what we try to bring in as Genworks. And we have collaborations that we have created for not just cervical health, also for audiology. Of course, we have done for radiology and cardiology as well. So, this is what I think is complete leverage of digital. The ability of leveraging the device, the expert, AI, machine learning, and making it transparent and seamless for everyone to access and to be able to provide treatment at the point of care. That's the big leverage that we are trying to bring. So, Anvit, you ready to go to the next slide? So, just as an extension, we have this ability to transfer. Ultrasound is one very important examination that obstetricians gynec, because in obstetrics and in pregnancy, there's nothing much that you can use from imaging as a technology than from ultrasound, because of the radiation issues. And ultrasound, obviously an image that's taken, the ultrasound obstetricians are trained, and they are capable of doing their own examination. But when in doubt, how do I seamlessly, transfer that image to an expert, and can that expert read that image for me and give us guidance to me, which is very, very important. So that the conclusion, you don't have to send for, a second opinion or a third opinion. It's just that, in a second opinion or a third opinion, all of us know what happened. We have to do the rescan all over again. Is it needed? If it's needed, obviously yes. The judgment certainly lies with the obstetrician. But for what is a doubt that you need to figure out, where we can, if there is a provision that our equipments can give you to push that image in the cloud and on the mobile phone of the expert. The expert can look at it from his mobile phone and be able to provide a diagnosis immediately, or provide his views to make a diagnosis collectively. So that's something again which is available in all our ultrasound machines, and we have a partnership with a company called Tricify, who provides this for us at a very, very less cost. This just doesn't cost much. For I think if you were to equate it for a per patient transfer, it costs about 60-70 rupees. That's all in Indian rupees, not much at all. But it's so much value. The value of the patient not having to come back again, the value of not being able to provide a conclusive diagnosis, the value of being able to determine the decision during the day, during the time when the scan has happened itself is immense, or at least during the day, if we can make an assessment and if we can guide the patient and if you can intervene quickly, that's the value of using technology, and that's the real value of what we are trying to bring as connected technology. And with the next slide. And there's more. A lot more, of advances are coming in terms of predictive treatment, and especially in obstetric gynec. We have signed up with a company called Genesis, which uses artificial intelligence to predict complications in women's health, pregnancy, and childbirth. So now, from whatever data that an obstetrician collects during the lady's progression during the pregnancy or even before, whatever information that they have in terms of their health status, their past history, their blood reports, the scan reports, all of this holistically is hosted in our cloud. And this company has got a phenomenal solution which we are going to launch in a few weeks. I thought I will share with you now, which we are going to launch in a few weeks, which is certainly going to be a very big change in the way we'll be able to prevent complications. When we predict complications, it's almost like we can prevent complications. And in pregnancy and childbirth, this is always one element of uncertainty. If this can help to reduce that, it's going to significantly reduce the burden. And that is what we have brought in here. So net, our whole focus is how we collaborate, how we use devices, how we use the intelligence, how we use predictive diagnosis, how we use AI, how we bring all of this together to be able to give the obstetrician or the gynecologist or the specialist a view of what they should take as a conclusive diagnosis and as an informed decision for them to make. And with the next slide. So this is what I said in summary. If I'm happy to take any questions, I'll be available. But in summary, a digitally connected device, a digitally connected ecosystem is very important in healthcare and certainly an essential in obstetric gynec. And because the overwhelming nature of this practice and the number of patients, the number of complexities, the number of unknowns that are there, that can, if we can solve for them, that's going to be significant reduction in, our maternal and, neonatal deaths, and of course, in gynecology, in the well-being of women in general, throughout their lifetime. So that's all from my side.
Prashant?
Sir. Thank you.
Yeah.
Ganesh, for the wonderful talk. Yeah. Sir, yeah, we'll take up all the questions later once the talk is done. Now I request Dr. Chinmay Umarji to start the session. And then after that, Mr. Madan will speak. And then we'll take up, we have two moderators for today, Dr. Mukund and Dr. Vinay, and Dr. Harish. Over to you, Dr. Umesh. Chinmay Umarji, over to you. You can start sharing the slides. You are there, Dr. Chinmay? Yeah. So I request Dr. Chinmay Umarji to give a brief introduction and then start the session. Over to you, Dr. Chinmay Umarji.
Yes, thank you. So I'm a gynecologist practicing in Pune. I'm a fetal medicine specialist, and it's a pleasure to be here and to get an opportunity to talk to you all. Thank you. So I'm going to skip a few slides for want of time. As you know, the cesarean rates across the country are going up, and on the other hand, the demand for safe vaginal birth, water birth, lotus birth, etc., has gone up. Safety in our mind as a gynecologist and pediatricians is the biggest concern, and thus fetal monitoring becomes crucial. Because on one end, there are unindicated cesareans because rightfully a gynecologist is worried about the baby. And on the other hand, there are lawsuits arising from fetal mortality and morbidity. On one hand, we have got intermittent auscultation, and on the other hand, we have got continuous CTG with advances, which we are going to see in a minute. These probably are the tests for well-being, fetal well-being, which are available with us. So ultrasound may not be available in the middle of the night. Intermittent auscultation is not good enough. And thus, we have to focus on the last four. And we are going to talk about these. And thus, when we try to talk about patients in labor, we want to stratify their risks. The big question is what constitutes a low-risk pregnancy? Because for low-risk pregnancy, all the standard guidelines, here I have quoted NICE guideline from 2020, say that do not offer continuous electronic monitoring. So why don't we go ahead and ask these guideline designers, what is a high-risk pregnancy? And we'll get a long list. And you'll realize that in many of our setups, these findings really depend on nurses picking up them. They may not be recording temperature that regularly. They may not be aware of how to monitor the labor. And we may not have qualified gynecologists on the labor ward around the clock. So practically, we are dependent on them for everything. And especially for single-handed setups or smaller setups where we do not have gynecologists on the ward, probably continuous electronic monitoring is the way out. Because here, at least you get to see what is happening. Mind you, this is not recommended by any guidelines. Guidelines recommend continuous electronic monitoring only for these conditions. You'll agree with me, it's a long list. But for these conditions, they say use it. What are the limitations of CTG? It is non-physiological, it is bed-bound. There could be a psychological and cost impact. As my predecessor said, cost of the test is directly proportional to the cost of the machine. And that is why CTG machines, even though many of them do not cost a lot, some of them may, and the cost may go up. You need expertise to interpret the CTG, and there could be loss of contact. There is evidence that cesarean sections increase by CTG monitoring and also the instrumental deliveries. However, there is no clear differences in cerebral palsy. Machine-wise, these are the limitations of CTG. So bed-bound patient, lose contact, inability to pick up signals in high BMI, and for water birth, there could be difficult monitoring. Advantages, of course, are for high-risk pregnancy, you need to monitor them. There's good medical legal documentation, and it reduces newborn seizures. So if we now want to invest in a machine, how do we choose one? So you want to have a machine not with one or two piezoelectric crystals. You would like 8 of them in a centripetal fashion with the 9th one in the center, which will pick up the signals. Usually they have inbuilt algorithms which can differentiate between, say, twins and mothers and the baby's pulse. An additional probe for twin monitoring is usually useful. If you have a patient with high BMI, and most of our cities now do have at least 10 to 25% patients who have a BMI of 30 or above, you may need fetal scalp electrode, wherein you attach the electrode to baby's scalp through the mother's vagina. Of course, you'll need ruptured membranes. Presenting part should be quite way down, and you cannot monitor babies who are in breech presentation. The machines with wireless probes are useful as they help with maternal comfort and they reduce the need of baby. Sorry. Can you mute yourself, please? Thank you. Machines with inbuilt pulse oximeter and sphygmomanometer act as a tool to monitor both mother and the baby. In my practice, I find admission CTGs quite useful for me. I'm not going to go into the details of interpretation of CTG for the want of time, and let us move on to the newer modalities. So you must know that fetal blood sampling is an absolutely essential tool when you're talking about interpretation of CTG and offering cesarean based on it. The other tools could be fetal scalp stimulation. So you are seeing an abnormal CTG. There is a good variability and there are multiple decelerations, more than 50% of the contractions, so they are variable. And you do not know whether to offer cesarean or maybe you can wait because patient is already 7 centimeters. In those cases, you can just pluck a hair or two with an artery forceps. You can stimulate baby's scalp, or you can do fetal blood sampling. This is a typical fetal blood sampling kit. Here is an amnioscope. Here is a wand which has a blade in it. These are the swabs to clean baby's head. There is a gel here which we cannot see, actually it is quite zoomed out. And this gel will help us, it's usually glycerin, which will help us localize the blood there. So what you do is, in a dilated cervix, say 3 centimeters or above, you put in this amnioscope. You remove the trocar, you'll see an auto light coming on, and you can see the scalp there. You clean the scalp with the swabs, apply some glycerin onto it, and take a small nick. You can get like a couple of drops of blood, 60 microliters is what you need, and run it on the bedside ABG gas analyzer. If the pH is dropping, or if the lactate is increasing, base excess is increasing, probably your baby is getting compromised. If it is absolutely stable, even with all those deceleration, probably your baby is managing very well, and you can buy 1 hour out of it. During that 1 hour, if your 7 centimeter becomes fully dilated, you can do a gentle lift out vacuum or a forceps and get the baby out. This is much safer than dilatation, than cesarean at 7 centimeter dilatation. Also saves time for you, cost for the patient. Moving on, again, to revisit limitations of the conventional CTG, where that the patient was bedbound, there could be loose contact. For high BMI, it is difficult, and it is difficult to monitor during water birthing. And that is why CTG telemetry is probably the next way in. What conventional CTG does is, it has ultrasound probes attached to mommy's tummy, and there are wires running from the probes to the machine. The very first CTG telemetries, what they did was that they just removed the wire bits of it. So there was still an ultrasound probe which would be attached and tied to the mommy's tummy, like this. Can you see it on the right? And that probe would continuously wirelessly talk to the base machine and give you the conventional CTG. Now, machines like these, which you can see over here, are called, they actually work on the technology of baby's ECG. So what they do is, they have a patch like this. They have a pod which gets attached in the center of the patch. The patch has got 5 electrodes around the pod, and a 6th one which is suprapubic. So all these five electrodes would pick up the signals from mother's heart, as well as mother's uterus, and from the baby. So these electrical signals are picked up and converted into waveforms. So the waveforms look exactly like our traditional CTG. However, as it is working on the basis of ECG, the loss of contact is not there. It keeps giving us the continuous. So you can, this was a mother with BMI of 38, and her CTG is working very well. Here is a mother who was delivering in water, and although the manufacturer says do not use it underwater, you can use it under showers, but not under water births. Her tummy was slightly above, and she could continuously be monitored. And here is a mother who is roaming around, and her baby is being continuously monitored. So your mother has freedom of taking showers, moving around. At the same time, your baby is getting continually monitored. I think GE has this technology currently, and a couple other companies are also going to share the patent with GE and work on the same technology. CCTG is actually a UK-based monitoring technique. This is used only antenatally. I'm not going to go in the details of that. STAN is ST waveform analysis, and probably this will rapidly replace our conventional CTG. What STAN does is, for abnormal waveforms on a CTG, it gives you an ST event. So if there is an ST event, it tells you that there is fetal myocardial hypoxia, which has started to set in. So if you have two such events, you would like to deliver this baby. So it makes interpretation much easier. You don't have to look at the CTG at all. Just look at the events. You've gotten two events, deliver the baby. So STAN, ST waveform analysis, is going to be the next big thing. It's already replacing many conventional machines in the UK. It is not available in India as of now. Fetal pulse oximetry, as of now, it is just emerging. It needs further evidence. Monitoring underwater could be difficult, but as I said, with telemetry, it's much easier. I'm not going to go into the details of that. What I can tell you is that I've been using wireless ECG with Monica patch for a while now. And here was a mother who was in her 7th pregnancy, no living issue, with diabetes, with high blood pressure, with antiphospholipid syndrome, with high weight. And I induced her at 38 weeks. Because she wanted at least 2 more babies, risks and benefits were discussed, and monitoring was offered. The limitations were that abdominal probe would have restricted movements. Because of high BMI, it could have given me loose contact, and fetal scalpel electrode would have been too invasive. So we went with Monica patch in her. That's a CTG back then. And this was back in 2017. Now she has got another little one in these COVID days. So thanks to wireless monitoring, you can deliver even high-risk mothers with great ease. I'm not going to go into these cases. Thank you for the opportunity. Over to you, Mr. Prashant.
Thank you, Dr. Chinmay. So now I request Mr. Madan to start the session, and we'll take up all the questions. I request all the attendees, if they have any questions, they can either directly WhatsApp me or put in the chat box, or you can WhatsApp for accepting a request in such a short time. Thank you very much on behalf of NNF Karnataka, and I request you to start the session. Over to you.
Thank you, Dr. Prashant. Thank you, NNF team, for giving the opportunity, and it has been going great. Even there has been a lot of learning for me, especially in the last 1.5 hours, from all the 3 speakers who have done a great job. So my intention today is, I don't want to get into the details of what is there in the market. I think as I'm addressing the entrepreneurs and the future entrepreneurs who wants to start the hospital. What is important for you is to understand how to do the purchasing in terms of what are all the process and methods that's there. And I will just touch upon the key players for all the laparoscope, bronchoscope, and cystoscope. Just a quick introduction about my background. I have close to 20 years in procurement and supply chain management, mostly outside India. I moved back to India just 5 years ago. I was heading Columbia Asia Hospitals for the group procurement. And recently I joined Aster DM Healthcare as its country head for procurement and supply chain management. Going forward, so to start with, I just want to elaborate on what is there in your plate when you start a business. How do you segregate your overall supply base, right? Because starting a hospital, you will have to go through right from the toilet papers till the ICU rooms. So it's not an easy job for any entrepreneur to clearly distinguish who are your critical suppliers, who are your strategic partners. Even when we come to all the consumables and equipments, what is key for you is to map the overall spend when you have a budget, certain budget, prioritize the budget, and map all the products in a matrix, right? So just to give you an example how it works, there are non-critical items which does not affect your everyday operations. So you need to have a clarity on which are all the non-critical items where I'm not going to spend a lot of time. Second are the leverage items. When I say leverage items, these are all the high profit items and the supplier risk is very less. So you have a lot of players in the market to give you these items. And also you can negotiate better because of the competition. So you need to know who are all your leverage suppliers with whom you have to buy these items, right? Third is on the strategic items. When I say strategic here, when we talk about the consumables, when you talk about a particular equipment, you're not talking for just a month or even a year. You're talking for a longer duration. So strategic partners are those where you need to have a clear relationship to have a relationship that will sustain for at least 3 to 5 years, right? So you need to have a clear direction on who is important for my business, with whom I can collaborate, I can invest on, and I will have a better visibility in terms of their products, and they will come and collaborate with me if they have any new products as well. So that is something very, very important, where the supply risk is also high. At the same time, profit margin is also high. The key ones are the bottleneck items, where we have very less manufacturers in the market, and the innovation and product substitution and the replacement is not available much. And in terms of production based scarcity, so you have to be very, very careful with these items, which you need to segregate and understand from the market, with whom you cannot really negotiate for a better deal. At the same time, you have to be very careful in terms of relationship management. So I thought I'll just touch upon overall on the equipment management plan. How do you segment your suppliers and your products? Right. Moving forward quickly, I will just go through. I saw the time, we have very less time available, but what I will do is I'll quickly show you who are all major players and what consists of in the bronchoscope, laparoscope, and the cystoscope. When we talk about bronchoscope, obviously the market is fairly fragmented. We have quite a few players in the market, where we have Ambu, Fujifilm, Hoya Corporation, Karl Storz, Olympus, and Teleflex. So you can, I don't want to go into each and every product because these are all ever evolving products, and you can get into the website of these players and see what is available in the market that fits your requirement, right? When we talk about bronchoscope, obviously we have flexible and rigid. And when you are looking into the cost, so in cost, what is important is you cannot look for something that is cheaper today. You need to look for, there are two variants, total cost of ownership and total value of ownership. So here what I have done is showing you the total cost of ownership. So you need to look into the capital cost, how much you're going to pay today. what is going to be my repair cost, what will be my maintenance, what is the backup anesthetist cost, cleaning supplies and equipments, cleaning personnel, operating room. So this gives you the total cost of what goes into each and every equipment, so that you can define your margin and ensure that you don't end up losing money when you are doing a particular case study. When we talk about laparoscope, again, it's a huge market. It's an evolving market. As we can see, by 2026, they expect particularly Asia Pacific and also India to be the main player in terms of laparoscopic instruments. Right? When we look at the supplier base, again, we have Ethicon, we have Conmet, Medtronic. These are all the main players where we have for the laparoscopic. Obviously, we have Bebron and Fujifilm. All these players can give you a wide variety of laparoscopic equipment instruments. And the global laparoscopic instrument market, by product, you have all the video, fiber laparoscopes, energy devices, infiltrators. All these are part of the overall the laparoscopic tower. Again, cystoscope, we look at the major players. We have Karl Storz and Olympus, so we have very limited number of players who can who has a varied number of items that they can offer you. So in terms of the pediatric system, they offer significant enhancement in the overall urology care. Right? So main thing what we need to look here is the total value of ownership. When you are going to buy a certain instrument or equipment, there are 4 levers that you need to consider, not just what you're going to spend today. We had to look at overall pre-assessment. You have the acquisition cost, you have the support, and you have the final disposition. So what is pre-assessment? Obviously, you analyze the technology, you create a project management because you're investing a lot of money into each and every equipment and the consumables for longer duration. And you look into the equipment analysis, you study the equipment, ask them to come make you demos in your hospital, wherever you are. Check for lease management, check for rental. There are even pay-per-use or upright purchase as well, based on the budget and scope what you can define. Capital budget cycle, contract negotiation. So there are various terms in the contract which you need to be aware of when you're going for a rental contract or a long-term AMC contracts. Equipment acquisitions, installation and acceptance and payment. So these are all part of the pre-assessment and acquisitions. So looking at the support, what support do you have in terms of recall management, device repair analysis, whether you have the suppliers who come to your hospital to do the repair, and do they have the scope on the perimeter to wherever location you are in, service contract and lease centralization, parts procurement centralization. Again, you cannot buy from different players every single time because you lose on the overall margin. You have the asset management, you have the asset reallocation, the sale, disposable or donation. So this is the overall life cycle of each and every asset that you have inside the hospital. So quickly to give you the procurement technique, what you have to focus on when you are procuring any of these instruments or the equipments. First, make the list of surgeries plan. What is going to be your monthly volume or everyday volume, and what are all the treatments you're going to offer. So that will change the entire view of what kind of equipment you are looking into, right? In terms of cost, in terms of your investment as well. Select the vendors who can offer the above instruments and equipments. Let it be, as I mentioned, pay-per-use model. You can even have the equipments. You don't have to buy anything. You just pay as you use them. You have the capex, you have a lease, and you have rental. So whichever model fits your business plan, that works for you. You ask them to have a demo of the product, and in fact, you can tell them you want to use on few patients in live surgeries to know the pros and cons of different makes. So the running cost of the product, as I told you earlier, the total cost over the life. For example, for laparoscopic system, typically it's 5 to 6 years. You can take how many surgeries I will do in 5 years, what is going to be my overall cost, and do I have my return on the capital investment or not. cleaning of instruments, be very particular when you talk to these manufacturers if there are any specific tools required to be confirmed prior to procurement. Example, the plasma sterilizer for laparoscopic telescopes. So these are all the additional costs, the hidden costs that you may not see when you're buying these items. And negotiate for the final price, the best warranty. So warranty is something that's really important when you negotiate for the equipments or the instruments, so that you don't have to pay for at least the first couple of years, which will be part of the equipment cost. So ensure the service is available from OEM or dealer at their respective places, and ensure to have the rate fixed for laparoscopy and broncho consumables for a certain period. So you cannot have different rates on an everyday basis. You need to have a contract, a rate contract per se, to have these costs fixed to at least for a year or two before you sign the deal with the manufacturers. I'm happy to take any questions if you have. Over to you, Dr. Prashant.
Thank you, Mr. Madan. So now the discussion is open because there are a lot of questions which has come up. The first question, I don't know whom to address to. How to decide on procuring an equipment more than 1 crore, or either rental or on a lease basis, and how should we crack the deal, or how to negotiate with the vendors or the person who is investing. Who will answer? It is open to all 4 speakers. Now I request Dr. Mukund to have a few words. He's our panelist, and Dr. Vinay as well.
Yeah, thank you, Dr. Prashant. No, this was an excellent presentation by all the speakers. So especially when I was listening to the talk, no, I was more interested in procurement of the surgical instruments and some laparoscopic instruments. See, Mr. Vinod presented in a very good way. The good part in India is customization and easily accessible. Because I was in US, no, because the instruments, the forceps, it's a big process to get anything here. The vendor comes to our hospital, and as THC said, no, I have small vascular forceps, 4 inches, small device for my neonatal surgeries and all. That's a very good thing by the Indian companies, where with less hassles, we can have the custom-made instruments according to the surgeon preferences. That's a very good thing. What we are encountering in India right now.
Yes. So the question which I have asked, so I request our speakers to one of them to answer the question. Shall we start with Madan?
I would like to have the question repeated, Dr.
Yeah. See, the question is how to decide on an equipment, surgical equipment, which costs more than 1 crore, to go along with the rental basis, or on a lease model, or on complete outright purchase. How to decide on that, and how to crack a best deal, how to approach basically for this particular equipment. You want it for an hospital, which costs say around say 3 crores, and how to go about, whether to purchase outright or what are the techniques which we need to use.
Okay, so when we look at equipment purchase, there are a few players in the market. Let's say we go with GE or Philips or Siemens. It is always better to have tie up with one particular brand where you consolidate all the equipments with one player, right? So that they look at you as a strategic partner, and they will give you the deals which they give for their preferred clients. So what is important is, as the question says, whether we have to go for a lease or pay-per-use or the outright purchase. So when you go for pay-per-use model, obviously you need to check whether the cost really sits into your overall breakdown of the particular surgery. Let's say you charge someone 1,000 rupees, right? And when this pay-per-use model, what you're going to pay for particular segment, whether it contributes 20% or 25% of the overall cost that you charge the patient, and how much is the margin that you get overall. When you are looking at lease model, again, you need to have the tenure fixed. Let's say you have a lease for 3 years, and after 3 years, what are you going to do with the equipment? Are you going to buy back the equipment, and what is going to be the cost? If you're not going to buy back, so what will be your investment after 3 years? So this is something very important, because most of the people, they go for a lease model, but during the end of the lease, if you don't have clarity in the contract, what am I going to do after 3 years? Again, you really need to look into the entire capex, or the lease would have increased significantly. So you need to have more clarity depending on your business case. I wouldn't really recommend outright purchase unless there is a clear investor who's ready, who wants to get rid of the capex and get these equipments done. But the ideal way is to go for a pay-per-use model wherever applicable, so that the entire maintenance services and the upkeep of the equipment is taken care by the manufacturer.
Yeah. So extension to this question. For example, if the equipment has been brought for pay-per-use, and if what is an ideal percentage per year we get as a return for that? Say, suppose if the investors has put, the vendor has put 4 crore machine, and in a year he's getting, say, 10% of the total investment every year, more than 10% per year. So what is the ideal percentage at which the hospital should buy back the particular machine, and what is the situation where they should continue to go with pay-per-view, pay for pay-per-use? Like, say, see, if you take a bank interest 7 to 8%, if EMI will be there if I take 4 crore loan, if you keep around 8% interest. Suppose if you are if someone else is investing and going for a pay-per-use, 1 year you see that they are crossing around 10 to 12% rent you are giving to them. So what is whether it is 10%, 12%, 15%, what is the percentage at which the hospital should decide that they should go for a buyback? So how to crack a deal in buyback? Like, should I tell them that whatever we have given you revenue, say 4 crores we have given, and 1 crore they've got it as a rental for 1 year. So should they go for deducting that 1 crore, or should they tell that 12% depreciation or 18% depreciation of the model? How to get in that picture, about the approximate picture?
Yeah, I got the question. So when you plan for a capex, usually you go with a business plan overall, right? As I mentioned in my slide, you need to know the overall volume, what you will do per month or per day, because even if you go for pay-per-use model, you need to give a minimum guarantee of how much you will do every month. So you cannot go for get equipment and use only pay-per-use and not just do one particular surgery in a month. That will not work. So you need to say them, okay, I will pay at least for 500 surgeries or 500 cases. So when you consolidate the overall value, what you pay, let's say you sign the pay-per-use for 5 years, a deal. So after 5 years, within 5 years, how much money you have overall paid, and let's say you have equipment for 4 crores. Per case, you pay 500 rupees on the pay-per-use model, and the minimum of 100 cases per month. So you'll be paying close to 50,000 a month, right? So when you pay for 1 year, it's close to 6 lakhs, or for 5 years, it's going to be like 30 lakhs. But the equipment value is at 4 crores. So what you have to see is what is the depreciation value of this equipment after 5 years, and you have to do the math along with the equipment manufacturer, considering all the warranties and the equipment condition. You tell them, okay, this will be the price. If I want to buy this equipment after 5 years, this will be the cost. So if you can mention that in the contract initially itself, after 5 years, you can pay that minimal amount and get the equipment. If you don't mention that in the contract, after 5 years, it will be whatever the manufacturer says will be the price for it.
Okay, so the same question on the vendor end. So I request Ganesh ji that how do you crack a deal? Suppose if you are a vendor and you are giving equipment to the hospital, what is the thing which you are looking at as a return? Say 8%, 10%, 12%, 15%. How do you decide? Same example of 4 crores if you take. How you crack with them, and what is the best deal for win-win situation for you also and for the hospital also?
OPEX model or a pay-per-use model is risk sharing. Basically, we are sharing the risk, and we are taking it in our balance sheet. We are taking the asset in our balance sheet. Obviously, we'll have to factor for, whatever we say, we have to factor for the interest, we have to factor for depreciation, we have to factor for maintenance. And as I said, since it's risk sharing, it's very important that, we have to have this conversation right in the beginning, so that both the parties understand. And as much as we heard, from Madan, that it's important that there is a minimum commitment which is always baked in, and how much ever we call it as pay per use, there is a minimum guarantee baked in, and there is a monthly payment that goes out. And so it's very important to understand, from the vendor and from the vendor side, it's important for us to lay it out on the table, tell you the pros and cons. Both has its own pros and cons. Obviously, now when you buy an asset, you are responsible for the asset, and you will have to be responsible for making the EMI payments. You're responsible for servicing the equipments, whether you get patients or not, or you get as many patients or not. It's something which is like a fixed outflow from you. You'll have to bring in from whichever sources, and also your balance sheet becomes heavy. The more you bring in assets on your books, your balance sheet becomes heavy, and your ability to leverage for future funding will be very limited, because your banks will say that your balance sheet is already over leveraged. So when you want an expansion, you will find it very difficult. So it's important to figure out what are equipments that are something which you can do from your own capital expense. These are basically equipments where about your return of revenue. Which I would certainly suggest that you have to take it on your own books, because the return of revenue, the pattern, you are assured about the return, and you're not going to overpay anyone, the vendor. Whereas there are a lot of procurements which can happen for devices where you are unsure about the return of revenue. There may be a novel product, there may be something which you're not very sure, but you want to provide that facility. Then there's a very clear understanding that you can have with the vendor. So from a technology equipment perspective, from the experience that I have seen, all these large value equipment, big value equipments. Of course, ultrasound is something which certainly can go on a pay-per-use model, but PNDT does not allow that, because PNDT is only issued on the person who's using it, putting it to use. So rental model in ultrasound, while it's a nice thing to have, it's not allowed. But if you look at products like CT or MR or the high-end equipments, it's the vendor it's a high cost intensive products, so that the vendor would not be would not be willing unless they are assured of big commitment on volumes from you. And if you're going to give that commitment of volume, you can as well buy it yourself. But there are a lot of products and services, like for example lab equipments. The model itself is a reagent rental model, because there's a consumable play in all of those. Because there's a consumable play in that, the vendor knows that you will have a consistent revenue, and he's going to upfront invest on the asset, which is the device that you are buying, and you're going to continually buy reagent. And typically services, wherever you have equipment where services is also involved, the vendor is conscious, and he's going to make a balance between the cost of services or consumables that he's going to provide versus the asset cost. And that's going to make the relationship much more better for you to take it forward. But if it's a large equipment, if it's something which is a technology where you are assured of a return, and that volumes will catch up, if you get into a pay-per-use model, you will certainly end up paying much more. Of course, once you decide that, you not just at the end of tenure, even on products that you decide to move, my suggestion would be to have an exit after 11 months, an option for exit. You can talk with the vendor, you can tell them that, okay, 11 months, let me try. If I can pick up volumes, I will want to buy it back. And what is the procurement price? Many vendors would even try to adjust for whatever you paid. Many of the models that we do is like that. We adjust for what you paid, and we try to convert the rest into a loan. So it's tailored for each product, each customer. So it's important to have a discussion. But the basic guidelines that I would want to give is, where you are assured of a return, where you know you're in control, where you know that if it's high cost and the vendor obviously would ask for higher commitment of return, it will be better for you to manage it yourself. Where there is a vendor will be keen to do is where there is a consumable play, a consistent concurrent purchase, either as consumables or services, is when he will be willing to do where he'll be able to put in a solution for you, which is a win-win situation for both of you. Certainly, the vendor will factor much higher interest than you, because the interest that you get is much lower than what we will get. Our borrowing is at 12 to 13%. Now it's even 14, 15% now. So now, if I have to give you a machine, I have to factor all that and give you, a picture, give you a, pricing. Whereas when you buy, banks are willing to give you an 8%, 8.5%. So now it's going to make your EMI lesser. So that's why it's important. So for which devices, to buy where your interest cost will be lower, what is the minimum return, and you will be able to deal with that. My advice would be for you to go with that. But where you, believe that there is a partnership value, which is just not giving an equipment and then providing service for it, but it also includes constant consumption of reagents, services, or whatever, is where I think it will be better to move to the rental model. And even there, I would suggest that you can, while you have a monthly guarantee, you can also ask for an exit, maybe after 6 months, where you tested it, and if it works for you and you want to take it back, or someone's or another exit window at 18 or 24 months. And of course, the residual value after whatever the tenure. The low-cost equipments, the residual value can be looked at even at end of 3 years. But if it's a high cost, you will have to obviously give it a longer term and look at and build a residual value. And it's important that you discuss and put it part of your agreement, so that nothing comes as a surprise for both the sides.
Yeah, Dinakar sir.
Yeah, Prashant.
Yes, sir. Yes, sir.
Yeah, Prashant, can I ask the same thing?
Yes, sir. Yes, sir. Please go ahead, sir.
First, my question to Chinmay. Chinmay, are you there, Chinmay?
Yes, sir.
Hello, doctor. Thank you very much. Your talk was very good. And it was very informative too. CT, what you were telling about the CTG, it's a wireless technology. Yeah, we know that mother can even we can put that wireless system on the mother's tummy, so that mother even can walk, go to the toilet, she can come back, so that everything will be recorded there in the monitor, so in the CNS, Central Nursing Station, or wherever in the labor room. Is there that monitor what we are managing? Because I don't know. I saw only in the exhibitions what is CTG wireless. I didn't use. I don't know. My question. We have to keep it near that where the labor room is there, or we can keep it in the Central Nursing Station. Where we should keep it?
So basically, it's like a typical CTG machine, which comes with an extra appendage. So if I may take a liberty of sharing the screen again,
Prashant,
how the machine looks like. Here we go. I'm just trying to do that. Bear with me for a second, Divakar sir. So basically, it's like a regular CTG machine, which which will come with an extra appendage, which has a Bluetooth pod. So like any other Bluetooth, it would be expected not to be disturbed by the barrier. So how you can manage that?
Can you show
physical barrier? Any physical barrier? I'm just trying to share the screen. There we go. Yeah. So as you can see, here is a small screen over here, and there is a charging dock for these blue pods. Okay. Now this screen is connected to the conventional CTG machine over here. Now there is a sticker or a wireless patch which is connected to the mother's tummy, and I have taken a pod. Can you hear me?
Yeah. What you do is when you are showing your cursor, press with the left hand, press the control button, and at the same time show the cursor also, so that it will highlight.
Okay.
Control button and cursor, it will become highlight. First control button, then highlight.
I'm doing that. This is the portion actually.
Yeah,
that's the pod. Now what has happened is I've taken this pod and I've taken it over here onto mommy's tummy. Now what this pod is doing is it's accepting electrical signals from the mother's heart, mother's uterus, and the baby in the mother's tummy. And it is collecting them and sending them back to the dock.
Yeah.
Now this dock is communicating those signals through the wires to the CTG machine.
Okay.
The CTG machine converts those signals into the mother's pulse, contractions, uterine contractions, and the baby's pulse.
Yeah.
Now, if you want a central nursing station to get all this data, what you need to do is you need to have the mother and the CTG machine in the same room. The distance between CTG machine and the mother could be as far away as 30 meters.
30 meters or 30 feet?
30 meters.
Okay.
Provided there are no physical barriers in between.
Okay.
So that is practically not possible in majority of the hospital setups. However, if that is sorted, then you can connect this machine to the central monitor.
Yeah. The same thing.
The central nursing station can keep taking the data.
Yeah. The same thing. Suppose if from one hospital, if they are shifting the mother to other hospital high risk because of some other reason, how can we know? Sitting in the example, our ambulance has gone to 50 kilometers away. So from 50 kilometers away, one hospital shifting the mother to high risk. So how can I, sitting in my hospital, can know about CT going on or not?
So with this facility, it's not possible because you'll need that machine to be there. And as you can see, it's a bulky machine.
Yeah.
It also needs current, so it cannot be.
I don't keep CTG machine over there in the ambulance. That's, I want to keep only what we fix on the mother's tummy. We are going to do.
There used to be. So Monica had developed that technology before, but Monica was later taken over by GE. So I presume that technology is not that readily available anymore. This is called home monitoring or ambulatory telemetry, wherein there is a different type of machine which patient attaches to her own tummy. And then the machine will send signal to the email and that can be sent to you. However, the problem now is that I don't think it is available. And when it was available, I remember 5-6 years ago, at that time also, it would not kind of pick up the signal very easily. So even for doctors, it would take like 5-7 minutes to attach it. So for non-medicos or paramedics, it would be slightly more difficult.
Okay. Mr. Ganesh?
Yes, sir, I'm there, yeah.
Is there anything you people have developed for transport during the transport central, our people, central where we are getting the references? Can we manage there itself? Is there anything you have?
I'll have to check on this, sir, because this device, I'll have to get more details. I know about the mobility. I know about the fact that, it's remote and it can be used within the hospital. But to your use case, we'll have to see. If you ask me, technically it's possible. We need to get we should be in a position to be able to pick the signal and transmit through a device. So, but I will come back to you on this as to how we can, be for making it remotely available. It has to obviously sit in the data should be transmitted to the cloud and should be able to pick it up. So let me check and come back. I am not sure about this.
Thank you, Ganesh. Prashant, can I ask the other thing if you don't mind?
Yes, sir. Before that, only one question regarding the first part, continuation of the first part. I'll finish off that question, sir. Then you can continue, sir. If it's okay. See, what they've asked two question is, it is for Kishore Kumar sir also can join us and contribute for this question. How to, is there a way to prevent capital gain cost for an equipment? Or can we, if you have bought an equipment with paying tax, can we avoid or can we show in a different way where the institution get benefited? Basically, they are asking, can we overcome the tax, especially the capital gain tax, when we purchase an equipment and when it run for a year? Kishore sir and other speakers also can contribute for this.
See, I think most of the speakers have addressed your questions in a big way. I think especially Madan and Vinod Nair have addressed the questions of equipment. One of the things is, I think Ganesh Prasad probably can relate to our dilemma. See, when I came back to India, I was specifically looking for Fisher and Paykel because those are the equipments which I had worked with in Australia. And unfortunately or fortunately, the company in India was not that forthcoming, and we landed up with the GE. The advantage of buying from a company like GE, which I think Madan was alluding to repeatedly, was you come under their favorite customer and also get a lot of deals. For example, GE has a lending the finance team, which can work out everything and give you the best possible calculation. So you don't need to employ somebody else. The other thing is, though it's been 15 years, we hardly have any repairs on the GE equipments. The AMC and CMC, what we have with GE, is sometimes we really feel, is it worth it? Because it's hardly comes to repair. So you need to take the longevity into consideration. You need to consider the maintenance problems and other things into consideration. The finance, if you want, going with the companies like GE will provide those expert advice, and you don't have to scratch your brain, depending upon what is your need, whether you want to convert that into OPEX or CAPEX, and all those things will be worked out by the GE finance team. Otherwise, you will have to have a good auditor or finance advisor who can work it out, because when you are trying to become an entrepreneur and trying to rise a hospital, too many small things, if you try to get into, you will go mad. And I think the professionals are the best people to advise. It all depends on what is the budget you are going to spend, what is the amount you are going to spend, and over what period of time you are going to depreciate the equipment, and what is the, I think if I remember, Madan was talking about the residual value. What is the residual value of that equipment at the end of 3 or 5 or 10 years, depending upon when you write it off? And what is the depreciation value, whether you depreciate 30% in the first year, 20% in the first year, or is you depreciate 10% in the first year? There are too many calculations. I think you need to know all those calculations before you can decide whether you can write off the capital or whatever. So in that sense, there's quite a lot of factors that need to be taken into consideration. And it again depends on the amount you're paying for an equipment, and what is the depreciation value in principle. These are the major points you need to consider, and then you decide what you're going to do. Because if it's going to be an equipment of only 20,000 rupees, then there's no point in taking all these factors into consideration. But as you questioned earlier, Madan, if it is going to be equipment which is going to be 1 crore or 2 crores, then it's probably better to calculate all this, and lease is the best way to go. So generally, as a rule of thumb, the higher the value of the equipment, better to go with the lease arrangement than buying it, because the equipment becomes old technology within a few years. But every rule has an exception. So as a general rule of thumb, the higher the value of the equipment, better to go for a lease arrangement, so that you can write it off lease as a OPEX rather than a CAPEX. But again, as I said, every rule has an exception. You have to decide what is your cash flow, what is your plan, and do you want to buy it back from the company at the end of 5 years, or do you want to replace that with a new equipment and new technology? All that you need to consider. And I think the best persons to answer those two questions are the experts are here, Madan and Ganesh Prasad. Over to you, Prashant.
Yeah, Mr. Madan and Ganeshji, please.
Yeah. So I agree with Dr. Kishore. It has to be tailored. It has to be completely. All this completely depends on the kind of information that you provide based on what you think as what is the right fit for your hospital. All those plans are available. Every plan has pros and cons. I mean, as I said in the past, while we can argue for OPEX, we can also argue for CAPEX as what is better. It depends on your ability to churn the revenue. So it depends on your wanting to replace equipments. It depends on your footfalls that you are expecting. The rate of growth that in footfalls in your hospitals that you are expecting. Of course, we have to go with some assumptions, but I don't want to be giving an presumptive suggestion on this. I would rather want to look at this as a good discussion between the purchaser and the vendor, to be able to explore our options. The good thing is companies like GE, larger companies, have the appetite for all of those. Many of the smaller vendors may not really have the appetite to do such transactions, so they will more push you towards buyout, simple purchase. But larger companies, and given the scale of the equipments or the supplies that they can bring in, the financial tie-ups that they have, so they will be in a position to be able to provide these options for you to consider. So it has to be tailored for individual use. Broadband. I mean, it's moment it's on OPEX, it's on somebody's books. So now, what is the security? What is the guarantee? Who's going to take that risk? And are they going to take it for no reason? Or what are the coverage that they're going to take to make sure that those risks are retired? And all of this will add a financial impact for you. Are you willing to take that, versus are you willing to deal with it yourself? So that's the point. So that's why I said typically companies will like to share risk where they see a consistent revenue trending, which is not just procurement, but what you buy as consumables, what you buy as services or whatever from them. And so their risk is retired. Risk is retired to some extent. So they will. It will be easier for them to take that call. But if there's a good reason, and if you find that compelling for you, you can go that path. So it's important to have a financial consultant. And as Dr. Kishore said, companies like GE have one who will work for you in the back end and provide you those details.
Yeah, Madan, you would like to add anything?
Sure. I'm sure Dr. Kishore mentioned it very clearly. So just comparing on a layman's view, right? It's equal to whether you want to just buy a Mercedes and spend for all the maintenance and what you're going to do with after 5 years, or you want to take a Ola or Uber just for the particular purpose for a month or so and go with some other option. So the same way you have to look into the capex as well, or you go to the Zoom car, rent the car for like 3 months and use it however you like. All the maintenance, fuel, everything is covered, right? So it's your personal choice depending on the overall cash flow what you have. How do you want to spend the money? Do you want to put all your money into one equipment and just be behind the equipment to give you revenue and take care of it, or you just pay per use or go on a lease model where you don't really have to worry about the equipment maintenance and see what's going to happen if you keep it for a longer term?
Thank you. Dinakar sir, yes sir, over to you sir.
Yeah, the same thing, sir. Kishore sir, you are there. The same question, I think so for Madan and even Ganesh Prasad also. Suppose if anybody wants to buy, approximately, it is for people who are really there. Suppose wants to buy 1 crore rupees equipment, example, because I don't want to talk 4 crore and all. Simple 1 crore rupees equipment. Example, one ultrasound 2 machines, or ultrasound 2 machines and one machine. So if they have 50% of the cash with them, so they don't want to go to the bank, but they want to take it. So they want to pledge with the company only the machine till they pay. Is the company is giving EMI basis with the bank, because bank interest once again everything will come, or that company will only give that in their own company. Previously, some other companies they used to give without the bank EMI, which is which is better like that, because they don't want to go to bank once again buy that. So what is your suggestions?
I think Ganesh Prasad is the right person to answer this, because he has worked with the GE and they have. I'm going back to GE because we have dealt with GE and we had a good, a relationship, and they can cater whatever your needs are like that, depending upon what is your cash flow. So if you are saying that you want 2 equipments and you want the whole thing to be organized as 50% loan and 50% deposit, then there are multiple ways you can do it. Is the remaining 50% going to be loan, or depends on, or do you want to pay EMI, or do you want to consider that as a lease arrangements? That's what I'm saying. It depends on what is the. I mean, you are saying 1 crore. 1 crore among what is your budget of the hospital? If you are building a multi-speciality hospital, which is around 400 crores is minimum, then 1 crore is nothing. But if you are building a small nursing home, which is going to be about 20 to 30 crores budget, then 1 crore is a huge outlay for most people who are starting a small hospital as a single-handed person. So there are lots of factors that need to be considered, and that's why I said there's no one glove fits all. You need to see if, like for example, Prashant Gowda is opening a hospital of 20 crores. For him, 20 crores is nothing much. So he'll just pull out of one pocket, buy everything in one go, and not worry about anything. And so it depends on what is your cash flow and what is your ROI expected, and what is your intention of the equipment at the end of 5 years. If you say ultrasound is becoming, technologically advanced very fast, like for example, 15 years ago when we started, it was 3D ultrasound was the biggest thing. Then it became 4D. Now it's become 5D. So it keeps changing so much so that you have to be abreast of the technology. So in such cases, it's sometimes better to lease it out on a lease model, especially if you are going to be a small hospital. And that way it can be written off for tax, expenses. Whereas if you buy, it becomes a capital expenditure. So, but at the end of the day, as I said earlier, I'm repeating that because it depends on each person's needs and what is the total outlay of the budget for the whole hospital. Madan is working, for example, Aster. Aster has got deep pockets and they have got cash loaded, and they may not be interested in leasing it out. They may want to buy it out outright. And so it depends on various factors. I think probably Ganesh Prasad can answer more.
Yeah. So the straight direct answer is any credit is risk. So now there will be a risk assessment, whether the bank is doing it, and also it will carry a interest. No, the way it is structured will be in such a way that you are not seeing that what is factored for interest and what is factored for risk. Both you have to factor for risk and you have to factor for interest as well. So now it depends on relationships as well. So it completely depends on today. If I am willing to place a 50 lakhs to Dr. Dinkar's point in his 1 crore procurement, if I am willing to place 50 lakhs as a deferred payment from him, number one, what is the tenure? Number two, can I take that call? Because organizations take calls depending on the comfort that the leaders have with the customer and the past track. Of course, there will be a little bit of credit evaluation that will also happen in the back end. But with all this, if I take the risk, it's based on my comfort with the customer that yes, this customer is going to pay me. And number two, if I'm going to defer something, I'm going to defer that, and I'm incurring a cost because I have procured it. And when I have procured it, even if it is GE, we have bought it from the make center and it has come into inventory, and that inventory has an inventory carrying cost. And that inventory carrying cost in some form of fashion, either as a, we may be willing to reduce the margins in the deal, and may not be wanting to pass it to you completely, but some portion certainly will be passed. We have to be cognizant to that. And third factor very clearly comes from, what you want to do. I mean, what today, if it's just a simple deferred, it's not a big deal. It's a question of discussion, understanding and comfort, which somebody can make a call, make a decision. But honestly, during times as this, many companies, even big companies, shy away from taking those risks. In a situation as this, the kind of economic recession that we are going through now, on business slowdowns, cash flows are very tight for everyone, so they will normally not take any such on their books. But still, there are some special customers, preferred customers. They will certainly want to take the leap of faith and support the customer. So now, again, when going back to our question on whether lease or on rental certainly for ultrasound is not possible because PNDT will not allow the equipment to be on somebody else's name. The person who's you all know this very well. So the purchaser should have the PNDT. It cannot be, because it cannot be in Genworth's name, then I give it to you, or some bank's name, and they lease it to you or rent it to you, and the PNDT cannot be in their name. So that's been a bottleneck for quite a while. I've tried my best to solve for it, but I have not been able to crack the date. Maybe there are solutions, but I am not aware of anything at this point in time. But when it comes to high cost, capital equipments, my sincere suggestion would be, if you are able to get a loan and if you know that you will have enough footfall for it, preferred is that, because that cost that you will have versus the cost you will pay for any form of structure, that will be lower, because your interest cost will be lower than what companies are paying. And of course, if you can make a good deal and get them to match that, then risk is with somebody else, and so you don't have to worry about it. You can go with that. So that's why these conditions have to be discussed, tailored, and we cannot give a commitment based on without an understanding of the customer or the customer needs or the expectations.
Yes. Thank you, Ganesh. Thank you, Kishore sir. Thank you. Dr. Chinmay?
Yes.
To tell you very frankly, I don't know about the corporate hospital. Dr. Kishore Kumar sir might be doing fetal blood sampling, scalp sampling, but I don't know. You told this is I read and I am reading and I am teaching to my student, fetal blood sampling should be done. This only it is like an fairy tales, but I have not done in my life. I have not seen. I don't know. I don't know. Okay. Are you doing in India? Anybody is doing? Is it routine?
I'm doing it.
Okay.
Sorry?
No, is it routinely they are doing?
Yes, yes, I'm doing it routinely. I don't work in a corporate setup. I own my setup. We do have an Abbott created handheld blood gas analyzer, which is bedside. So in the longer run, it is kind of cost effective, but in the shorter run, it is a bit expensive at around 7 lakh rupees. And also the cost of the testing is a bit high because the cassette costs somewhere around 400 or 500 rupees plus taxes. So cost per test is also quite high, and you need to do cord blood gases. So you'll be doing like 2 cord blood gases per baby. Plus you'll be doing skull blood sampling maximum of 3. Good news for all of us is that slowly and steadily, what I had mentioned there was a slide about physiological interpretation of CTG. So that is slowly and steadily replacing skull blood gases. So
Yeah, that's what
as of today, the guidelines say that skull blood sampling is the current standard, but maybe 5 years down the line, the current standard may change.
Yeah, that's what I asked, because even when we are teaching them, when we are reading about the perinatal thing, CTG is better. Fetal blood sampling, if we were not expert, and because I don't know. So Kishore sir, are you doing in your hospital fetal blood scalp sampling routinely, sir?
No, we do cord blood routinely. From day one, we have been doing cord blood gases for all the deliveries.
Sir.
But we don't do scalp vein sampling routinely. Probably, so each center we have roughly about 200 plus deliveries a month, and we may end up doing cord blood, scalp vein analysis once in 3 months on one baby, if there are clinical indications. But cord blood gas we do routinely, not the scalp vein.
Yeah, sir. That's the reason I asked, sir. Because anyhow, it's a good Chinmay, and okay, and sir, it is for Kishore sir. You are the pioneer in obstetrical and neonatology, and I want to ask for the question to Mukund, and Aster Hospital person, Doctor. Sorry, I forgot his name. I am sorry, sir. Madan. Sorry, Madan. Bronchoscopy, cystoscopy, and what is it? Laparoscopy, endoscopy. We know that one company is having one specialized, like Olympus, Stryker, and Carlstone, like that. The thing is, suppose you are telling always one player is better, one player is better for the service and other things. Yes, we do accept it. For the initial who wants to start the hospital, and Dr. Mukund is also their pediatric surgeon, and Dr. Vinay, are you here? Dr. Vinay? Dr. Vinay? I think so. Okay. Mukund, are you here?
Yes, sir. I'm listening to you.
Yeah. Okay. See, suppose if Vinay is, see, Dr. Mukund is also.
Yes, sir. I'm there, sir. Vinay.
You are there. Okay. Okay.
Yes, sir.
Vinay, suppose if we
Yes,
are
sir.
starting. Yeah. So Madan, this is the question, and Kishore Kumar also should answer. My question is, starting hospital, spending almost 80 lakhs to 1 crore rupees for bronchoscopy, cystoscopy, and laparoscopy, pediatric laparoscopic adult, and all that means endoscopy, all those things will be huge expensive, up to 1 crore rupees it will come, including tax, or it will come plus also. So Madan was talking, in case if it is a starting hospital, why can't you go for the rental or a lease basis? And you can talk first, only you should talk for the what is it, after 2 years can we buy, instead of spending the more money on that for the purchasing of equipment. How we are going to decide which companies are better for all those things if it is a one player?
It's a very good question, sir, because it was going on our discussions very often. The least thing I was also not knowing, because when I bought my BMW car, I purchased outright. But when I going through the ads and all, these things really works out, because the amount of bronchoscopy, because when you take a set of bronchoscopy, starts from 3, 3.5, 4, 4.5, and 6, depending on the age of the child. because the 3.5 bronchoscope, it's we use in once in 3 months. And how many bronchoscopies I do right now? Maybe 8 to 10 in a year. How many cystoscopy collaboration I do? Maybe 6 to 8 in a year. So taking that into consideration, leasing is a good option. As a center grows up, as a team grows up, we can buy it back. It's really works out rather than spending 80 lakhs to 1 crore buying all the instruments. Leasing is a very good option to, take it forward. What do you say, Mr. Madan?
Madan?
Yeah, I completely agree. I think when you have lesser volumes, it's better to go for a leasing or have a proper tie-up with, let's say, Carl stores and ask them what kind of arrangement you can have in order to secure your overall cash flow. So these are the only options. Buying everything and just keeping it idle is going to only spoil your overall cash flow scenario.
How to bargain? See, our this thing is, sorry, it is not a over enthusiastic question. Should not feel. You people might be a good initially when you are joined for the purchasing. You also might be learning like me slowly. Now you might be expert. Like Kishore, how he is sitting like a king. See, when he was also there, he was also like me only. Now he became a master. Now he divided the work to people, and now he is managing like a king. Okay, when he was initial, like he's like me. So Madan, how you learn, what is the technique for the company to give for the lease? Please give us for the lease, said that we will pay it. So they will ask some for the lease, they will ask at least some 25% of the money for the lease that we are ready to give. Can you just give us a tips, Madan, and later even.
So overall, I totally understand his question, right? Even I'm not a healthcare professional. I've been out in automobile and other industries. So only in the last 5 years it's been more on the healthcare. So the advantage what I had at Columbia Asia is, okay, we built the Sarjapur hospital. I was from the start, and then the Pune hospital. Now with Aster, it's Whitefield and the other hospitals which we are newly building. I would say it goes back to the relationship, what you're going to have, the trust and the brand what you have created over these years, right? The companies are predominantly not going to just look at a person and give. Obviously, if it's Dr. Kishore, it's a different scene. But looking at me, they're not going to give any particular credit. It goes back to the brand and the company with whom you work for. So when you deal with a particular service provider or manufacturer, when you make it as a complete package, put all the equipments and the consumables what you need, you can significantly reduce the cost, because the margins what they have it's huge, right? When it comes to biomedical equipment, when someone is saying 100 rupees, you start like how you bargain in the Chinese market. You start at 20, but you never know what is the actual cost. You end up in 35 or 40. So when someone is telling the cost, that should not be your reference point. You should look at how much you can charge a patient and how much margin you need for your hospital. From that, you need to go on a bottom up approach, so that you have clarity on what is the maximum you need to spend for that particular equipment. So that should be your reference point, the top end during the negotiation. So you can't buy something on a very expensive rate and not charge the patient accordingly.
Kishore sir?
Yeah, look, it depends on which company you're dealing with. See, generally, as a rule of thumb, I'm sure some companies will hate me for saying this, but you learn over a period of time that you can bargain up to 20 to 30% on the equipments as a general rule of thumb. But again, it depends on what mode you are taking. See, beyond certain limit, the equipments, they can't reduce the cost of the equipments. So that time you can bargain for some consumables or AMC or CMC, depending on what you're trying to do. So ultimately, the companies will have what they call as a reserve price, and the reserve price they won't reduce it any further. One of the ways is you can probably what you are doing is the right thing. That's exactly how you learn. You talk to people and you find out who are using that equipment. Call that hospital. Do you have a purchase order? What is the price you paid? So over 2 or 3 people, you will learn what exactly is the price. Say for example, somebody could have paid 7 lakhs, somebody could have paid 6,90,000, somebody would have paid 7 lakhs 5,000. So at the end of the day, you know that the lowest price they are given is 6,90,000. So then you can say, you give me for 6,90,000. They may say they may not be able to give. So you learn by talking to people, and certainly webinar is that's what you are trying to do. So you will learn by that way.
Yes, sir. Okay. Mr. Vinod? Vinod?
Yes, sir, I'm here.
Yeah, Vinod. So your input, because you are surgical items, so you are the owner of the THC, surgical items, beds and all those things. So how surgical equipments you are selling, beds you are selling, surgical everything you are doing it. So what about the bronchoscopy, cystoscopy? You will be having so many of your friends. Almost Kishore sir is telling almost up to 30% you can go ahead and bargain. So what is your because it is belongs to your this thing, bronchoscopies are all those things. What is your carry things?
Sir, from my experience, the multinational companies like Olympus or Richard Wolf, or you take it CalStores, these people, they work in two ways. One is we have to purchase from upfront, which is an expensive thing. Here, what my experience, these people won't give us a credit or any kind of upfront purchase only one way. Otherwise, like Dr. Kishore mentioned, Mr. Madan mentioned, the second option is that since this is very expensive way, these people give us a lease basis, or these people give us the finance basis. Some of the companies like GE, is not manufacturing, but still that kind of companies. So here, what my suggestion, if the return of investment is not in line with your expectation, better go for a lease basis one, because this is very expensive equipment. Not like we manufacturing the stainless steel equipment, this is very expensive. So it's depending on what kind of business you are into. That is how many beds hospital. If it's like Dr. Mukund mentioned, if it's 5 or 6 per year which are coming, it's little difficult to bring that money into your book, and it's going to be a burden for you tomorrow. That's from my sir.
Thank you very much. Thank you very much for all those things. Okay, Dr. Vinay. Dr. Vinay. Dr. Vinay.
Yes, sir. Yes, sir.
As a surgeon,
Yes,
as
sir.
a laparoscopic and bronchoscopic this thing, as a cystoscopic person, because you are doing all the all the gynecological side also, you are doing the laparoscopic procedures, and surgical side you are doing, and you are very good laparoscopic cholecystectomy and even liver this thing you are doing. What is your opinion?
Yes, sir.
Because you are already running a polyclinic and you are having all those things, and you are going to be a big hospital
Yes,
owner
sir.
too. What is your carry things when initial? Do you think endoscopy is different? I want you to tell endoscopy, no, we have to buy. Bronchoscopy, no, we have to keep it. Because in bronchoscopy, reusable bronchoscopy from smallest size to this size, we will get it in 1 lakh. That we have seen in the BLIC, that is a Bangkok International Exhibition Conference. And even in the Dubai, we have seen it. That even reusable continuously, that we are going to get it in 3-4 lakhs. That you have seen bronchoscopy, cystoscopy too, even for fulguration. What is your opinion as a surgeon? You are running, keeping all those equipment in your polyclinic.
Sir, depending upon the specialty, since our surgical field mainly depends on the quality of the equipment we have, And also to do, we have to have a definitely good number of cases. So once we are investing, we expect at least we do 5 laparoscopies per week and at least around 10 to 15 endoscopies per week. So if we have such expectation, definitely I would prefer to go for a better equipment and to purchase our equipment. So, and when we are planning to purchase such equipment, I prefer to have a good quality one, especially the laparoscopes and endoscopes and all. As of now, we have very good high definition one which has NBI as well as infrared. So depending upon the specialty, since I am a GI surgeon, I prefer to have the infrared radiation as well as in all the Indocyanine in green, that is IR vision, these things and all. I would prefer to have. But once we are investing, again, we should see the budget of the hospital. So initially, since it is difficult to invest everything in such a short time, depending upon the patient footfall, I think we can invest one by one instead of investing at a stretch over all the equipment. So this is my opinion, sir.
Thank you, Dr. Vinay.
Yes,
Kishore sir, Kishore sir, you are having multiple branches. It is a small. I know that you are specialized in the gynecology. This thing also. You had a pediatric hospital also started. It's a clinic. Sir, your experience, because you told in one class, I bought and I put it something colposcopy or something. Later it was there for a long time. You told in a first class or somewhere you told. I have forgotten.
No, you're absolutely right. I think just now you heard that you go stage by stage, because see, for example, when we started, we had bought equipments for everything, including colposcopy, including urogynecology workshop, because we had a urogynecologist and we wanted to offer everything for women and child except oncology. So we had bought even the urogenic instruments for assessing the bladder at manometry and all that, which was costing about 20 lakhs equipment altogether. At the end of 5 years, we realized that we had not used any urogenic equipments for 5 years. Colposcopy, even after 15 years, we have not used even once. But people keep asking, do you have a colposcope? So over a period of time, we realized that some of these equipments you could have done without using it. So sometimes it's better that you rent it out or lease it out for a couple of years to see what is the patient load, and then probably decide buying it rather than having everything and not using it.
Yes, sir. Yes,
For
sir.
example,
Thank
the
you very much.
urogenic equipment which you had bought for 20 lakhs, after 7 years, the depreciated value was only 3 lakhs and we sold it for 3 lakhs, which had not been opened up. So sometimes you realize that you may not need to invest in everything in one go. So
Yes, sir. Okay. So
back to you, Nitin.
Prashant. Yeah.
Yes, sir.
Ganesh, somebody's talking. Somebody's talking. Ganesh.
Something is not
Yes, sir.
normal.
Ganesh, in technology, your talk was really good. All the slides we have seen prepared nicely with, I think so, more quality was there in that. Just I want to ask, technologically wise, gynecological, what is your carry home things for the hospital?
Blood test, ultrasound.
I think somebody is talking. I don't know who's talking. I'm able to hear.
Prashant,
Singh, can you mute?
them?
ಮತ್ತೆ CT scan also.
Prashant, can you mute? Yeah.
Yes,
please,
sir.
Ganesh.
So yeah, please. I didn't hear the question, sir. Please tell me.
Sorry. No. See, your talk was very good. excellent slides and more informative for the future technological wise about the mother side and how obstetrical side. So can you tell us, for who is building the hospitals, what better future things it is going to be there, and any message from your side?
So basically, I think for obstetricians, it's very important that they have to decongest themselves from, the intense, intensity of people that are wanting to wait for them. So especially in the new normal, where we need to be careful about coming in contact and for promoting safe access. It's very important that they create a workflow which is seamless. This is just a guidance. This is a personal suggestion, because having waited many years or many days outside obstetrician's office, I always think as to how stressed they are, because they are stressing themselves, because everything almost always depends on them, and that's going to be very difficult to deal with. And that's also the reason why they are completely overwhelmed and they are not able to use even technology which they procure. Many of them buy ultrasound machines, many of them buy devices, but they don't even use those, and they refer outside because they just don't have time. Just imagine if you have 50 patients waiting for you in a day, 50 OPDs. We can't do any OPD less than 15-20 minutes of quality time is needed, and that provided if they come with all the information, if all their vitals are checked, their history is checked, they come with all the reports in order, then it takes that kind of a time. Otherwise, it may even take half an hour, 40 minutes or whatever. Just imagine in a day, there's only a finite amount of time that is available. And in that time, they obviously have to do labor and delivery, they have to deal with emergencies, and of course, they have to take some personal time for themselves. So now it's very important that maternity homes, obstetricians, create a protocolized working, which is very easy to do nowadays. And that's why technology plays a vital role. Is it everything that they have to be involved? They have to first clearly understand where I have to do, where my paramedics have to be involved, and where I can come in. And is it everything that the patient has to come and has to do in the same time and congest the system, or can they do it in a separate time and be able to free up that space, effort, and time for them? Everything has to be done face to face. Not necessarily. There are times when you don't have to do face to face. You can look up to teleconsulting. It's about completely seamlessly, creating a process, protocol, and training their staff, and also making sure that customers understand the value of why they are doing it, and they have to completely decongest themselves. That's primary. Number two, my sincere and humble suggestion to them is to be able to leverage point of care devices, because a lot of point of care devices which are not expensive give them valuable insights which can help them to make an informed decision. So they should use those point of care devices, and there is not overwhelming. They don't have to completely buy anything and everything that's available, but there are some basic essentials which every maternity home should have, and they should have it. And also it's important that they look at who they buy from, because they don't have time, because they don't have support for procurement, they don't have anyone who's comparing and analyzing. Many times we know that they end up procuring based on what they see and what they hear. So now, in the absence of an ecosystem as that, they have to be extremely careful about where they put the money, for what technology, how the technology is being used, and they should be on top of all this. For that, they have to have enough time. So these are the three things which I would strongly suggest. Of course, anything else, they know what to do. I'm not anyone to say, but allowing them to be overwhelmed by the number of patients and the number of touch points, the number of interactions, and minimal use of technology, completely relying on outsourced diagnostics. These are the things which they can very nicely avoid. And certainly all of this is going to also make them make their cash flows much more better. Otherwise, they will always be under stress and strain of managing cash flows, because cost of healthcare, nobody is going to pay more. It's only coming down. A C-section delivery, the cost is coming down. Any hospital care cost is coming down, and OPD, what they collect as OPD fee versus what they deliver, the time they deliver, I don't think at all it's feasible at all. So now, unless they optimally manage and optimally and they are able to clearly lay out, how they can set themselves for and make sure what they will own and what they will manage, it's only going to be difficult for them. And certainly in the new normal, this has given us the opportunity. It's very difficult to change patient behavior. We all know this. Even when we go to big hospitals, we don't go, even when there's an appointment system, even when all these protocols, processes are set there. Typically, most of the time, almost all the time, we want to beat it. As a common man, I can say that. But then, times as this, should be leveraged to make sure that these processes are tightened, awareness is created, and we make sure that we do not, even post-corona, we don't dilute on all of this, and we can create a much more efficient system where the time is valued, their effort is much more focused, and the outcomes can be way better.
Ganesh, thank you very much. I think so. Mine is the last question for Kishore Kumar sir and for the Ganesh also, and Chinmay, and our Madan also, and our Mukund, Dr. Mukund. Okay, I think
Yes,
so.
sir.
People are okay.
Yeah.
This is the question. Sir, Kishore Kumar sir, whatever I am talking, it is the emotional word involving in the marketing, as well as we are also there in the field. Try to understand, sir, once again. It is an emotional marketing world where our consultants are going to come. Sir, at least your hospital should have this minimum basics. I know that it is not so much basics, but it is a feather in the basics. But that means it is once again a headache for the owner of the hospital. So on that grounds, I am asking, sir, minimum for the ultrasound, you to just now when you bought it was only 3D, now 4D, 5D has come. At least ultrasound, it should have best ultrasound, at least we need it, because people are coming for the 5D or 4D or anomaly scannings to the cities, metros, they are coming from the peripheries. So at least we should have a better machine in the machine in the periphery. So that will cost once again high. But I don't know how to weigh it is must or it is necessary. So, I mean, three things: mandatory or desirable or optional. How to, because it is must there, because that doctor is ready to use it and he can give the reports. The same way, what is it, bronchoscopy or laparoscopy, pediatric laparoscopy. I don't know how many people are doing neonatal or pediatric laparoscopics. Is it a must to buy in the laparoscopy one and the ultrasound machine one? And the second thing is like what we decided, no, we need a bronchoscope. We need, because I saw that for the bronchoscope, some corporate hospital of the pediatric who are there in the metro, they have only became famous or becoming famous because they have that equipment. I know that they might be using five times. Sir, if you'll go there, everything is there in that place. So I am not telling I will keep everything someplace. I know we should have a full stop. So what is your impression in the laparoscopy, pediatric laparoscopy? Is it necessary? Or buying ultrasound, is it necessary? But we should also have for marketing some measure. So where to put a full stop? I am not asking comma. Comma, I know where to put. Full stop, where to put. Greed, I don't think greediness are more desirable or I should have everything. This is not the thing.
So, Dinakar, you asked the question to me, so I'm going to try and answer as honestly as possible.
Sir.
For that, you need to define the population you are serving. So, if the population you are serving, say they have deep pockets, they don't mind paying whatever you charge, then you should have 5D, 6D, 7D, whatever the latest is. But the population, if you are serving, comes from a area where very price sensitive, and all the other hospitals are charging 500 rupees for an ultrasound scan. And if you have a 5D, then if you calculate the ROI of that equipment and various other factors, you may not be able to do it for 500 rupees. So what it means is you may land up losing the patients because you are charging more. They may say, well, I agree Dinakar has got 5D, but I'm not wanting to pay, 2,500 rupees, for example, for a 5D ultrasound, when I get most of the information here. And if I need to, I will go later. So the number of patients whom you will be treating will become less. So you really have to identify your target population and what is their affordability, or what is that you are targeting population, and what is the target number you are planning to achieve. So if you say, look, I'm going to be targeting only like 20 deliveries a month, for example, as opposed to 200 deliveries a month, then you target that segment and that sort of a thing. So you have to really decide what is your target population, what is your target pricing. Then you have to decide about equipments. I think that is the gist of what I can answer. Maybe
Yes, sir.
others have a different view, and you can ask others.
Mukund, what about pediatric?
See, I prefer to see the pediatric laparoscopy comes in two ways. No, one is undescended testis. It is very common condition. I am comfortable doing a laparoscopic orthopexy at the age of 6 months. So when I'm using for 6 months, what I need are the 5mm instruments. The 5mm camera is more than enough for a baby, or sometimes you can use the ENT scope for the as a telescope. But instruments, you require a 3mm, otherwise it is not possible. It becomes too problematic and bigger things for a small child. Then the pyloromyotomy, IHPS is very common. 3mm instrument becomes very handy. And the pyeloplasties, up to 1 year, I am very comfortable doing a pyeloplasties. The 3mm needle holder, 3mm instruments is not very costly at all. Then comes the cystoscopy fulguration. So what will happen, as Dr. Dinakar was saying, the reputation of the hospital referring out takes a big hit in the long run if you are saying that it's not possible in this hospital, you want to refer it out. For this kind of small reasons, we have to invest on a bronchoscope. We have to invest in a cystoscopy fulguration unit. It may be 3 in a year, but now everything can't be ROI, return of investment, because return of investment becomes, it will not come as a cash flow or the giving as interest. Sometimes it will bring the reputation of the hospital, and everything can be done in a single roof. That is going to give us a long-term benefits which can't be.
Tax invoice. See that reference number with the bill, whether it's the same which we had booked earlier. Oh. Cross verify.
Yes.
So that's my take on having expensive instruments that should be handy when you are treating a child.
Thank you, Mukund. Thank you, Mukund.
Ganesh, you would want to add anything?
Yes, sir. My personal view on this is we should not add equipment for marketing. That's not truly a suggested method. It has to be totally based on needs. There are equipments. Typically the cost of equipments. Take ultrasound for example, varies based on usage. What you need is the most fundamental thing, and what volumes you can cater to, and obviously, today, do you need all those features? And if you, why? First of all, let's just take a step back and look at why are we diagnosing. Now, if I am having an ability to treat for that, then I'll have to have a diagnostics. I'll have to invest on diagnostics. When I'm not, first, that's why it's important to look at what am I going to be able to handle? What am I going to deal with? We're not a diagnostic center here. Diagnostic center obviously is a completely different ball game. There they can do all of this. There they can look at number games, 64, 128, whatever number of CTs, whatever. That's different. I'm not even talking about that. When I'm talking about a hospital procuring or a nursing home procuring, it has to be totally based on what they need and what they can serve for. And even there, it's really very important to understand what I want to deal with. While I said that there are some essentials which they have to deal with, they should not outsource. But if there is something where you are not going to get volumes and you don't have to keep it on your head, it's not certainly going to give any mileage. It's only going to make you burden more with the repayments. You'll be many hospitals, we know with our experience, the relationship with customers, they have shared with us that, I am serving this from that, earning. A lot of people tell me that, my earnings are only from ultrasound, but I am paying for the CT from this ultrasound earnings. Why would you want to earn from, and this is a depreciating asset. This is not an appreciating asset. If you don't need a CT, why would you buy a CT? And if you're only going to do some 10, 15 cases in a week or some 30, 40 cases in a month, why would you even do that? You can very well refer that outside. Why would you want to pay for it? It's not going to improve the asset is not going to appreciate in value. It's not gold or land or anything. It's a depreciating asset. So now it's very important that, in a hospital, in a private setup, specifically in a private setup, in a nursing home, it's very important to clearly understand what am I solving for. To that extent, do I have the technology to support me? And what are essentials that I should have? I'm not supportive of outsourcing anything and everything, because that will discomfort the patient. That's when what was discussed will come up. For every little thing, if I want to have the patient to go to 3 different places, then that will discomfort the patient. And in times as this, it's a big fear as well to go from one place to other. But if it is for something which we don't normally use, or we don't have as much use case, and more importantly, if we can't solve for that, if you find something you can't solve for that and we have to refer somewhere else, then it's a good idea to even refer the patient for diagnosis there and treatment there, than to hold diagnosis here and send treatment somewhere else. So marketing should be based on totally what we are solving for. And typically in hospitals, I would strongly suggest, though I should not be saying this coming from a commercial side, but certainly to customers that we deal with or I deal with personally, I certainly provide this holistic guidance. Of course, if they want to go ahead, they go ahead. We are not here to stop anyone from doing anything. But for marketing sake, we should not add equipment. It will go away very soon. And those happened basically because of diagnostic centers venturing into such things. But that will go away very soon. And I have not seen anyone who has procured for the sake of marketing and really delivered. But if you're procured based on use case, they have really over delivered, and because they will get the return of money in any case. So that's my simple bit of guidance when it comes to procurement.
Yeah, thank you, Ganesh. Very valuable suggestions. Thank you, because some people, some well-wishers and some people do suggested some things you have to buy it to show also. Otherwise, there is a things. Okay, gradually what we learned today is step-by-step procurement, and either buy for the lease or rental if it is a new hospital. If it is running good, then go ahead and think and keep it with you. If it is a lease, initially only we have to make it ourselves. How much we want to buy it, everything. Thank you, all the speakers. Sorry, we took long time of yours. Prashant, over to you. Kishore sir, thank you. Prashant, over to you. Vinay, thank you.
Yes. Yeah, I would like to thank all the speakers. for sparing the time. It's almost 3 hours, this discussion and the webinar which is gone. Thank you for your valuable information. I'm sure this information, what we have stored now, what we have recorded, it's going to help because we will be putting it in YouTube. So thank you very much for your wonderful advice. Thank you one and all. Thank you. Have a great evening. Thank you.